Every new day brings with it immense possibilities to make this world a happier one. With such hope, we, the organizing team, going to start India's first ever 2 days International Geriatric Physiotherapy e-conference program, GERICON 2021. Hello everyone, myself Ms. Juna Shaha, a lecturer in computer science in P.D. Women's College, West Bengal, India. Technical advisor to the exercise testing and organization, prescription organization ExRxIndia, would like to wish you all a very good morning and warm welcome on behalf of Team GERICON 2021. Now, I would like to welcome on stage Ms. Arunima, Assistant Professor from Sree Anjaneya College of Paramedical Sciences, Calicut, Kerala, India. She did her Masters in Neurology and Psychosomatic Disorders from M.B. Shetty College of Physiotherapy, Mangalore, India. Ms. Arunima, please.
Session. It was really nice working with you. I sincerely appreciate your remarkable efforts and cooperation for the event. A warm and bright morning to all present here. Ladies and gentlemen, on behalf of Sree Anjaneya College of Paramedical Sciences, I, Arunima and Aroma will be your host for today. To begin the auspicious occasion, I invite the college choir to invoke the Almighty. Ladies and gentlemen, I request all of you to be a part of this prayer.
Gajanana Padmarkam, Gajananam Aharnisham, Anekadandam Bhaktanam, Ekadandam Upasmaye.
So thank you, Shamleka. Thank you, Nofa. Thank you, Devika. So with all blessings, let's start our session now. With immense pleasure, I invite
Gajananam Ekadandam Upasmaye. Agajanana Padmargam, Gajananam Aharnisham, Anekadandam Bhaktanam, Ekadandam Upasmaye. Ekadandam Upasmaye.
So with all blessings, let's start our session now. With immense pleasure, I invite and introduce my co-host, Mrs. Aroma, to hand over the session. Mrs. Aroma is an assistant professor, Sree Anjaneya College of Paramedical Sciences. Over to you, madam.
Thank you, Ms. Arunima, ma'am, for introducing me to start the session. Well, firstmost, I would like to thank all the respected dignitaries on and off the dais, delegates from India and abroad, and the entire organizing team for taking time out of your heavy schedule and making this spectacular event with your glorious presence. We are extremely privileged to have you all here in this event, GERICON 2021, India's first ever geriatric physiotherapy conference for physiotherapy care for older adults.
Next, I would like to invite beloved principal, Sree Anjaneya College of Paramedical Sciences, Calicut, Professor Dr. S. Makesh Babu. Sir possesses more than 19 years of national and international experience in both clinical and academic side. He has received award for professional excellence, Best Teacher Award, and Distinguished Academician Award in 58th IAP conference held on March 2020. We are indeed lucky to have you here as a principal and team leader in organizing GERICON 2021. With him as helm of affairs here, we hope to achieve new heights over coming years. Let's put our hands together for Professor Dr. S. Makesh Babu. I extend a hearty welcome to you, sir.
Thank you, Ms. Arunima. Very good morning to all. As the convener of this International Physiotherapy e-conference, GERICON 2021, first of all, on behalf of Sree Anjaneya College of Paramedical Sciences and ExRxIndia, I welcome the honorable guest, Mr. Anil Kumar V, Chairman, Malabar Medical College Hospital and Research Center, Calicut, Kerala, and Professor Dr. Ali Irani, Head of the Department, Physiotherapy and Sports Medicine and Rehabilitation Center, Nanavati Super Speciality Hospital, Mumbai, and also he is the chairperson of International Affairs of Indian Association of Physiotherapists and Principal NMIMS University. I welcome all the distinguished guests, Dr. S. Subramaniam, Dr. Savita Ravindra, Professor Narasimhan Swaminathan, Dr. M. Vijay Kumar, Ms. Nisana Suhail, Professor Parthasarathi, Dr. Kamraj B, Mr. Sreejit Namboothiri, Mr. Gopakumar, and all the participants for this e-conference with the theme Physiotherapy Care for Older Adults. Also, we are happy to announce that participants are from all over India and from various countries, including Australia, Singapore, Dubai, and Nepal, registered and attended this e-conference. And these 2 days e-conference, which is jointly organized by the Anjaneya College of Paramedical Sciences and ExRxIndia, is first of its kind, focusing on physiotherapy care for older adults. So with 13 topics, which includes orthopedic, neurology, urology, and community-based, with 11 speakers from India and abroad. So we also have the e-poster presentation on day 1 today and e-paper presentation on day 2 tomorrow. So normally getting older involves changes in all realms of life, from the physical to the mental to the social, emotional, and more. Some of these changes you may regard as positive and some negative. So the challenge is to maximize the good parts of getting older while taking proactive steps to maintain the health and minimize the negative aspects. I assure that all the participants will have good learning experience and a new dimension in providing physiotherapy care for older adults after this e-conference. At this juncture, I would like to extend my regards to our Honorable Chairman, Mr. Anil Kumar V, for accepting to collaborate with ExRxIndia team, that is Dr. Chandramohan, Ms. Duna, and Mr. Rupesh, for conducting this e-conference and providing me the opportunity to organize this conference. Our chairman, Mr. Anil Kumar's vision and efforts are very laudable, and he is the mastermind behind growth and development of all the institutions under the Anjaneya Medical Trust. And we are having Malabar Medical College Hospital and Research Center, the Anjaneya Institute of Dental Sciences, and the Anjaneya College of Nursing. And also he is currently the Secretary of Private Medical Colleges Management Association. I would like to kindly call upon our Honorable Chairman, Mr. Anil Kumar sir, to deliver few words about the conference. Thank you.
Good morning, honorable guests, Dr. Ali Irani, Dr. Chandramohan, and all dignitaries. A very good, warm good morning to each and every one of you. I feel proud to be a part of this kind of a webinar organized by the physiotherapy team of this GERICON 2021 under the heading, under the name GERICON 2021, with the theme of physiotherapy care for older people. You know, during this COVID situation, the relevance of physiotherapy. Yesterday, one inspector had come for some medical college from this as an observer. See, in our Kerala University of Health Sciences, when the inspections are going on for granting of courses, some observers will be there from other disciplines. Like yesterday, we had an inspection for MD pathology and MS gynecology and all that. 4 inspections were there. There, one physiotherapy professor was there who had come as an observer. He was saying me the possibilities of physiotherapy in the post-COVID scenario, because people are struggling with the post-COVID situations. Then they were struggling with COVID. Most of the people have lost their hopes in their life when they were addressing the wideness of the COVID post-COVID situation. And he was saying me there are ample potential and scope and opportunities for the physiotherapists if they really come forward to help the people who are suffered from this COVID pandemic. And then, of course, geriatric care. You know, India is burdened with the old age population. Our doctors are unable to support them, and most of the times they get ignored by the family members, by the society, by the doctors community, everyone. See, in the current situation, when this Prime Minister's scheme, but is that PMJY scheme is introduced in most of the states, at least these old age people are getting admitted in the hospital because the burden of the hospital are not to be borne by the family members. It will be borne by the government. So in such situation, these people are getting admitted in the hospitals. Otherwise, they were just passing their days till their death with agonies and pain. So it is a very welcoming step, an encouraging step, and a really really motivating thing that the Association of Physiotherapists have come with such a good novel idea. I wish all the success for the interactive programs. I will give all kind of supports, and I am the chairman of this trust which conducts this paramedical college as well as this Paramedical college. So we will give all kind of support in your future endeavors as well. Once more, thank you for inviting me to have a chat with you all this fine morning. I wish this program a grand success, and let it be an eye-opener for all the physiotherapists across the globe to have their career molded for the care of the geriatric people. And as I mentioned you, as I already mentioned, let it go in a long way to help the COVID and post-COVID people as well. Once more, thank you all, and wish all the best. Thank you.
Thank you, Anil sir. Thank you, Makesh sir, for your influential message and inspiring words. In this moment, we express our heartfelt gratitude to Dr. R. Chandramohan, founder, ExRxIndia, for this initiative in collaboration with Sree Anjaneya College of Paramedical Sciences. His endless efforts and determination have made significant contributions in exercise testing and prescription in most minimally addressed areas in our field. Sir possesses more than 17 years of experience and is currently working as a chief physiotherapist at Sree Samraj Physiotherapy Center, Dindivanam, Tamil Nadu. It's indeed a great pleasure to have you here, sir. I wholeheartedly welcome you to speak a few words. Let's put our hands together for Dr. R. Chandramohan.
Thank you, madam. Thank you so much, Arnima, madam, for such a wonderful introduction. I didn't expect it. I thought simply you will call me, and thank you for that. And good morning. Good morning to all. A warm welcome to all the dignitaries, delegates from different parts of our nation and Singapore, Dubai, Australia, and Nepal, and distinguished guests and honorable guests, especially Mr. Anil Kumar, Chairman, sir, of Malabar Medical College Hospital and Research Center, and Professor Dr. Ali Irani, HOD, Nanavati Hospital, Mumbai. Also is a chairperson of IAP, International Affairs, and Principal NMAMS. First of all, I would like to thank Professor Mahesh Babu, sir, for reaching us to do an education program. It was first decided as a small program, then it was extended to be a conference, and we decided how many days and how many topics. And the reason behind this conference is Arun Balasubramaniam, sir. He also told that why don't you do next conference, and he's here. Thank you, Arun Balasubramaniam, sir. And also I would like to thank Sundar Kumar sir from MS Ramaya, who is working in geriatric department, for helping us to make so many topics, what has to be discussed for these 2 days. And I'm thanking for him also. And following our successful international COVID conference, COVIDCon, and also research and future physiotherapy related topics, QuestCon, and this is our third international conference program regarding geriatric physiotherapy. And thank you, Mahesh sir, for giving such a wonderful idea to go with geriatric topics and naming this conference as GERICON. And yes, and always, whenever I approach Ali Irani sir, I'm going to do some program. He will be, the next message will be, I will be there. And he's such a wonderful person. Not only that, not only Ali Rani sir, Narasimhan sir, Sabita madam, Subramaniam sir, Arun Bala Subramaniam sir, Annie Thomas madam, and many physiotherapists who are always ready to help us to do educational program. If it is like an academic event, they are there for me to do. That's the strength of ExRx India to take any step regarding academic side. And yes, I thank all the dignitaries here, and I would like to welcome our chief, on among the chief guests, Honorable Professor Dr. Ali Irani, and he did his bachelor degree from MS University, Baroda, did his PhD in sports medicine, and PhD in anatomy of body movement and dance from Bombay University, Doctor of Physiotherapy in Spain, and he worked for our Indian cricket team during 1987 to 1997 for a vast years. And he is member board of studies, NMIMS University, as well as he is a principal there. And he presented papers on knee mobility, backache, hammer tone for frozen shoulder, fitness and sports injuries, and held workshops on innovative physiotherapy and sports medicine at various national and international conference. In fact, SAR is also a contributor for webinars and supporter for all our academic programs. And he's also a PhD guide for various universities in India. And apart from all these things, he is a very good orator, and he received a Hithra Oration Award in 1994, and having memberships in IAP, and he's also a member in World Physiotherapy Association and Gujarat Physiotherapy Council, Maharashtra OTPT Council. And without wasting much time on his profile, because he is well known, not needed more of intro, I welcome Dr. Professor Ali Irani sir to utter a few words regarding the upcoming programs.
Good morning, everybody. Welcome all the participants to GERICON 2020. My special thanks and wishes to Dr. Chandra Mohan for arranging innovative and lovely topics which the world wants to watch today. Especially the topic today is very dear to me, but I would like to give all my wishes to this exercise testing and prescription organization and the people behind the scene, especially Tuna Madam, Kamraj, Mahesh Babu, Anil Kumar. Thank you all of you for coming. Danny, and especially the two young ladies who will be taking this show for the next 2 days, Arunima and Aroma. I wish you all the best, and thanks. Thank you for calling me.
Thank you.
So as we all know, this 2 days conference is going to be on geriatrics, and I've already fallen on that age. I'm 63 and definitely falling under the age of geriatrics. I only want to tell everybody, science is going to increase the longevity of human being. We all are going to live more. It's not earlier, the span in India, I'm just talking during the independence time, they said, okay, average is what an Indian would survive was 62 to 68 years of age. But it has changed now. It has totally changed now. Now, all of us very soon will be crossing 100. It is because of the science. It's the way the science is taking us. We have answer to everything. If you feel you don't have a knee joint replacements are done, heart replacements are done, transplantation of kidneys are done, liver are done, lungs are done. So a person can live, the science has an answer to it. But as we age, I always say that a physician will add years to your life. A physician will add years to the life. But it's a physiotherapy that will add a life to these years. The quality of living is going to be very important. That is where we come in as a physiotherapist. Why? Because we require good quadricep muscles to stand or to walk or to balance ourselves. So strengthening of all these muscles is going to be done by a physiotherapist. So long back, we had introduced and made a gym. It was called a Geriatric gym. It's almost 8 years back in Patiala, still working. So I was during my talks of 10 years back, 8 years back, was that very soon there will be geriatric gym. So there won't be gym for bodybuilders and youngsters, but there will be gyms coming up for geriatrics, where we will be talking about basic muscle requirements, static exercises, balancing exercises, using TerraBand, using physio ball, making them play a game, because at that age, what they require is meeting other people. So I have seen people at the age of 70, what they could do, a 65 could not do. And that was an encouragement at each other. What's your age? He says, I'm 75. Oh, you are doing it so well. I'm just 65. So he said, no, you can also do it. So this gym will be treating people who are 60 plus, whether you call it a geriatric gym, whether you're going to call it a senior citizen gym, but definitely the future of physiotherapy is going to take one more specialty, and this new specialty will be in geriatric conditions. As we all know, we know our muscle and joints. So it's that we see all the muscle and joints of an individual is working with the right range of movement and the right strength. So we have a long way to go. I hope this next 2 days, Chandra Babu and his team are going to cover up all the topics. Sorry, I have missed Savita ma'am. If Savita ma'am is there, good morning to her. Hoping she would be also talking on this topic. My only request to Chandra Mohan will be, as I'm not in India, I'm talking from Dubai. I'd come here to sort out the problems with data flow and Dubai Health Authority not accepting IAP. So last 2 days I'm with them, and it's almost sorted out. Very soon we'll be getting an email about this. So I won't be able to be long because I need to do my running around, but can never refuse Chandra Mohan. I'm sure next 2 days are topics to do with geriatrics, and I wish I was in Mumbai so I could talk. I had a PowerPoint presentation which I had promised Chandra Mohan on geriatrics, but hopefully if I'm back tomorrow, I myself will call and come in sometime tomorrow if I reach Mumbai to do that presentation. Otherwise, in the next, I'm sure he's going to continue with his good work. So anytime, next time when I'm coming in, I'm going to talk to this. Again, once again, my best wishes to all the team. There's a lot of work to be done behind the scene. The team of exercise testing and prescription organization. Thank you, Dr. Chandra Mohan, and everybody who is attending this. I'm wishing you all the best, and my only hope that may God give you all a healing hand. Thank you.
Thank you so much, sir. It was a great pleasure for all of us to have such a personality among us. We rarely get this opportunity to listen to the words of a great knowledgeable speaker. Thank you, Ali Rani, sir. Thank you, Dr. Chandra Mohan, sir.
Just a second, madam. Yes, Ali Rani, sir, 63 years young. You are still young. You are not older enough, okay? You are 63 and still young. And we are also having a few more dignitaries who have joined with us now. I would like to welcome Shyam sir and Dr. Sheetal Raj, geriatrician. Welcome you all. And they are also reason behind this GERICON. Shyam sir helped a lot to set the topics right order, and Sheetal madam has helped us to go with the 2 topics, which are core topics. I welcome them, and over to Anjaneya madam. Please carry on.
I can leave Dr. Chandra Mohan?
Yes, yes, sir. Yes, sir. I will be sending you the link. You can join with us anytime for these 2 days.
God bless. God bless everybody.
Thank you, sir. Thank you, sir. Bye-bye. Yes, Anjaneya madam. Please carry on.
Now I would like to utilize this beautiful occasion to welcome our guest of honor for today's inaugural address. I invite Dr. S.S. Subramanian, sir, Principal, Balaji College of Physiotherapy, Bharat Institute of Higher Education and Research, Chennai, India. We are so privileged to have you here, sir. I extend a warm, hearty welcome to you, sir.
Yeah. Good morning to all participants. All present is over here for the inaugural function of GERICON 2021. And Dr. Chandra Mohan, the founder director, ExRxIndia. Dr. Ali Rani, distinguished physiotherapist. Dr. Mahesh, the principal of Anjaneya College of Physiotherapy, and all the speakers who are present over here for today's inaugural function. A warm welcome. Good morning. You know, let me just say a few words. It's so happy, delighted, because you know the Indian population has about 8.6% as geriatrics, and the rate is growing at a percentage of about 3% every year. So the potential is huge, and this is supported with an evidence of National Statistical Official Report 2021. It's hot. 8.6 of the total Indian population are geriatrics, above 60. And as we are growing with age, living longer means lots of problems physically, mentally, where we have falls, orthopedic, neurological, cognitive decline, can lead to functional disturbances, which can lead to disability and impact on our quality of life. So not much of research being done on geriatrics in India. It is an under-focused area, and probably I'm sure this conference will shed a lot of light on why this topic is chosen, and all the listeners I'm sure will benefit a lot by attending and learning with evidence. Start preparing more with geriatrics. Thank you for the wonderful opportunity. Thank you so much. Have a great day. Have a great learning ahead. Thank you.
That was really an amazing start, sir. Thank you, sir. I invite our next guest of honor, Dr. Savita Ravindra, working as professor and head of the department at MS Ramaya Medical College, Bangalore. I consider it as a great honor to welcome Dr. Savita Ravindra for the opening remarks. Over to you, madam.
Kindly unmute your mic, Savita ma'am.
Okay. Yeah. Thank you, Arunima. Good morning, everybody. And Chandramohan, it's always a pleasure to be associated with your efforts. And the question of saying no to him when he wants us to be there for a short while is always there. And I think everything and most things have already been spoken in terms of what people have expressed in terms of the need for gerontology to be taken forward as a specialty within a physiotherapy community. And very happy that the Anjaneya College of Paramedical Sciences have come forward to give a complete 2 days to this particular program. Keeping our elderly in the community and not in the hospital has a role from a multidisciplinary team, physiotherapy being one of the very strong links within that. And there's a whole range in which we work to keep them up on their feet and active. I wish the entire organizing committee, as well as all the participants and the presenters, all the very best. And thank you for having me come in and just be there to share in this part of the program. Thank you, one and all.
It's a pleasure for all of us to have such a great personality among us. Thank you, madam.
The next distinguished honor us with his presence, Dr. Narasimhan Swaminathan, Vice Principal, Sree Ramachandra College of Higher Education and Research, Chennai, India. Sir has done his master's in cardiorespiratory condition and he is a fellow of PIMA. With immense pleasure, we welcome you, sir. Over to you, sir.
Kindly unmute, sir.
Good morning, all the distinguished guests and members. It is a pleasure to be a part of this inaugural function. Congratulations to Chandramohan and his team for yet another important conference organized in online platform. I see Chandramohan and his team has created a history in Indian physiotherapy conferences and webinars. Congratulations to Chandramohan and his team. And I also congratulate the Anjaneya Institute of Paramedical Sciences for taking this forward. As the members already expressed, this is an important area we, the physiotherapist, needs to focus. The geriatric population, we have a major role. I saw the scientific program. It is very well planned, thoughtfully designed. I'm sure the participants are going to get best out of this conference. These kind of activities are much needed to deliberate the important issues such as geriatric care. Once again, I wish the team, I wish the conference a great success. Thank you all.
Thank you, sir. Sorry, madam, just a minute. I also like to wish Narasimhan sir for his upcoming physical conference. Sooner it is going to happen in Chennai. I wish you for that also, sir. And thank you for coming, sir. Over to Aranima, madam.
Thanks, Chandramohan.
Thank you, Dr. Narasimhan Swaminathan, sir, for your influential words. It's now my privilege to introduce Dr. M. Vijay Kumar, currently working as principal, Dayananda Sagar College of Physiotherapy, Bangalore, India. Sir has secured PhD, MSPT, FTSR from London and is certified in bioethics by UNESCO. With the long list of his achievements and glory, I would like to invite Dr. M. Vijay Kumar. Welcome you, sir.
Ma'am, kindly continue with the program. I cannot find sir in the list.
Okay, ma'am.
He may be joining a little bit later.
Yeah.
Kindly proceed with next.
Okay.
It will be my honor to invite our next guest, Dr. B. Kamraj, Principal, AKG Cooperative Institute of Health and Sciences, Kannur, India. He is a former Board of Studies Chairman at Kannur University and currently Board of Study member at Kerala University of Health and Sciences, Kerala, India. We welcome you, sir.
Very good morning to all. Actually, first of all, I am impressed with the way they organize, they plan, and not only they arrange many speakers, the area they have covered by the Sree Anjaneya Paramedical and particularly the Department of Physiotherapy. And as we all know that, so all the speakers, they told, like guests, they told about gerontology is the fastest growing field in the modern medicine. So we know, actually, normally we have concentrated physiotherapy in ortho, neuro, cardio, but in geriatric, but quality of life. So making any person independent at any age, whether he is 60 or 50 or 20 or 90, that quality of life is more important. So we should proud about, like, as Ali Rani sir told, making a person be independent. It's a more gifted one for anyone. And so they have arranged webinars now, so offline. I hope it will be like online now. So I hope like we can go for offline within short period. So I wish very all the best and thank you once again for the organizing team for making me the part of this e-conference. Thank you. Thank you so much.
Thank you, sir. Thank you so much for your words of wisdom. It will be a great pleasure for us to listen to you again in our future events. Now I call upon Miss Arunima.
So now let's have a pleasure of listening to the opening remarks of Honorable Guest, R. Gopakumar sir, President of Kerala Association for Physiotherapy Coordination. We welcome you, sir.
Good morning. I hope you can hear me.
Yes, sir. We can hear you.
Good morning, Dr. Mahesh sir, Anil Kumar sir, Kamraj sir, Daini sir, and all other dignitaries, Srijit sir, I think during this COVID period, the first physiotherapy college in Kerala to use this e-platform to promote the physiotherapy profession as good. We KPC sincerely congratulates its organizers, Anjaneya College Management and Principal Professor Mahesh, and I sincerely hope that there will be more discussions and debates in this forum. Although the number of colleges is increasing exponentially, we must not forget the fact that physiotherapy sector has not grown properly in India in the past. I wish all the best to this event by reminding everyone that we need to work towards the growth of the profession and thereby the discussions that need to be done to increase the job opportunities for the new students through such conferences. Thank you for inviting me and I'm representing KAPC, the state organization in physiotherapy. Thank you. Thank you, Mahesh sir, Danish sir.
Thank you very much, sir. Thank you very much, sir, for your session. It was full of enthusiasm and valuable words. So our next distinguished to honor us with his presence is Dr. Sree President, IAP Kerala, India. Currently serves as a position of Director and Chief Executive Physiotherapist at Center for Physiotherapy, Trivandrum, India. We welcome you, sir.
Good morning, all. Respected legends of physiotherapy in India and national and international level. I'm happy to represent this GERICON on behalf of IAP Kerala. We have been honored to give an opportunity to be with the legends of physiotherapy who have come across here. I would like to enlighten that we have a great role in dealing with the geriatric issues. We know that as age progresses, we will be developing so much of musculoskeletal disorders, which may lead to many other systemic dysfunctions, which may make the old age people to be in bed and dependent on their daily activities. I promise that community that physiotherapy can assure you getting older gracefully with our healing hands. As you know, we have a role in maintaining the strength, joint range of motion, functional activity, and everything. So we will be able to make them a part of the society, a part of the active member in the family. And I would like to congratulate the Anjaneya College of Physiotherapy in organizing such a webinar on management of webinar. I know that there are 12 topics, 14 international and national presentations, and experts in the fields like Savita Ravindra, Narasimhan, so many of my friends like Basil, so many are participating in this event. And as Ali Rani sir said, we can add life to years, especially for geriatric life. And as Kamraj sir told, I think Kamraj sir told, so we can, we are the only professional we will be able to make dependent people to become independent. I would like to wish all the organizers and participants very best for the event. Thank you.
Thank you, sir. Thank you for your words. Next, it will be my honor to invite Ms. Nishana Suhail. She's a head licensed physiotherapist at Abu Dhabi, UAE. Welcome you, madam, for a few words. Ms. Nishana Suhail,
Nishana
madam.
ma'am, you are there in the Zoom. Kindly unmute and join video, please. Ma'am, we may invite her later. Can we continue?
Hello.
Yes.
Okay, ma'am is here. Ma'am has joined. Ma'am, kindly join video.
Yeah,
Nishana
one.
ma'am.
Yes.
Yeah.
So good morning, everyone. So nice to be participate in this wonderful e-conference, and congratulations for Dr. Chandra Mohan sir for this great venture. So regarding our main topic of physiotherapy for geriatric people. So a physiotherapist working with the older people can be considered as a jack of all trades. That means it's a far from being a term of belittlement, the phrase that is term of respect for all the skills a physiotherapist needs to apply to their patients in light of the biopsychosocial model to ensure a holistic patient-centered approach. So it's a wonderful opportunity to be as a distinguished guest in this conference. Thank you for invited me for this, and all congratulations and all the best for all the speakers out there, and thank you so much.
Thank you, madam. Thank you for your valuable time. The next distinguished to honor us with his presence, Professor Parthasarathi sir, Principal at Meenakshi Academy of Higher Education and Research, Chennai, India. With immense pleasure, we welcome you, sir. Over to you, sir.
Has Parthasarathi sir joined the session? I cannot find him in the Zoom meeting participant list.
Mahesh sir, I request Mahesh sir, can you check with?
Yes, sir. Yeah, 1 minute.
Sadi sir, please. Yes. Meantime, we can move on to the next guest.
Kindly unmute Arunima ma'am.
Yes, ma'am. So I'd be delighted to welcome Dr. Chandra Mohan sir for inviting the first guest of honor.
Yes,
So
madam.
first,
Yes.
Chairperson, Dr. Sheetal Raj.
No, madam. I will handle it now. Please wait. Please wait. Sheetal madam is there?
Yes, sir, I'm here.
Yes.
Yes. And
Satya madam is there, sir, online.
yes, madam. Please wait, madam. Mahesh sir, please.
Satya madam is online, sir.
Satya madam is online. Yes, sir. Before we start scientific program, I would like to invite Dr. Sheetal Raj, the geriatrician. And she's here. I forgot to put her name on the slides. At last, I found her here at right time. And thank you, madam. Thank you for joining with us a little bit early for scheduled time for you. And I welcome Dr. Sheetal Raj to utter a few words regarding this geriatric care for the older people for 2 minutes. Yes, madam, please.
Thank you, sir. Good morning to all. I would like to thank Dr. Chandra Mohan for inviting me, and I'm happy to be at this conference to see so many wonderful professionals and administrators also who are working to make physiotherapy in older adults and improve science. I would like to say that I have always, Sham is a physiotherapist whom I work with, and as you know, Sham, we have a great time working together. So I think one thing I would like to say is that this is the time for interdisciplinary care where most doctors, I don't know your personal experience, but until I was introduced to geriatrics, my experience has been that we work in separate departments, unconnected to each other, and apart from giving each other references, we don't mingle much. But there's a lot of benefit in working together. The benefit goes to the patient, and I think the challenge today for geriatrics is to, especially for geriatric physiotherapists, I would say, is to make yourselves available to the patients. Nearly all my patients need physiotherapy. even the fittest of patients need physiotherapy, and physiotherapists are not available as much as we need them. So I think to all the administrators and principals here, I would like to say that then the challenge is of access to physiotherapy and also of quality, because there is a lot of need for community-based rehabilitation today, where patients request for physiotherapy care to be delivered within the homes or near to the community rather than to go to hospitals, and that is usually the core need for a geriatric patient today. And there is an immense need for physiotherapy support, and I think physiotherapists, as has been said by many others before, you start where we stop as physicians, and you provide solutions where we feel there are no answers. So there is a need for us to work together, and I think today's the conference today and tomorrow will probably enlighten us more regarding the finer aspects of what a geriatric physiotherapist should be aware of, and encourage, if there are students participating here, to probably take up geriatric physiotherapy as a specialization so they can spend more time with physicians and help us to deliver better care to our patients. Thank you, sir. Thank you for inviting me to this conference.
Thank you, madam. Thank you so much. And madam is working in Kasturba Medical College, Mangalore, and accepted our invitation to be one among our guests. And also she is going to take two topics for us, two main topics for us. And we are waiting for your presentations also, madam. And kindly stay with us, madam.
Yes, sir. Sure.
Yes, yes. And sir, Mahesh Babu, sir, can you please check whether Pathasar sir is coming now?
Yeah.
Dear participants, dignitaries, and other guests, kindly wait for a few minutes so that we will be checking. Duna madam, can you please check Vijay Kumar sir has come or not?
Not joined yet, sir.
Has Satya madam joined?
Yes, I'm here.
Yes, yes, ma'am is here.
Yes, madam. Please stay connected for a minute, madam. Mageshwar, kindly check whether Pathasar is coming, or we can move on to the next scientific session.
Yes, sir. 1 minute, sir. Yeah, take it.
Magesh Babu sir, it is okay that whenever he joins our program, we can ask him to utter a few words, and we can move on to the scientific session, sir, if it is okay for you.
Okay, sir. We'll go ahead.
Shall we go ahead, sir?
Yes, sir. Yeah, yeah.
Yes. Thank you, sir. Thank you, sir. Thank you.
So that
Good morning, all.
marks-
Good morning, all. Sorry to interrupt, Arunima. I would like to give the information for these 2 days and what we are going to see for our participants. Then it will over to you. Okay. And good morning, all. This is Chandra Mohan, physiotherapists would welcome you all again for the scientific session now. And I request Dr. Rupesh to post the message in GERICON WhatsApp group that the scientific session has started. And for 2 days, we are going to see almost 14 topics. One topic has got cancelled due to unavoidable circumstances. And today we are having first topic as comprehensive geriatric assessment. It will be taken by Dr. Sheetal Raj. And the second topic is physiotherapy in surgical and non-surgical spine. Will be taken by Dr. Vinil Pillai. And the third topic, adaptability in community among neurogeriatric conditions, will be taken by Dr. Annie Thomas. And balance and falls is the fourth topic, will be covered by Dr. Girish. And fifth one, degenerative joint disease in the elderly, will be taken by Shyam Krishnan. And the topic 6 is extended care for older population, will be taken by Sanjay Epan Samuel sir. And 2 more topics are there that after that we will be having added Muhammad Yasir Sah's topic today and Ajim Shah Sah, MS Sah's topic today, that is critical and acute geriatric care for physiotherapy perspective, will be taken by Ajim Shah. There is a slight change here that it will not affect our regular programs. It will be aligned to have before post-lunch session, but after lunch. And another topic today is inflammation redox imbalance and effects of self-management exercise in knee osteoarthritis. And also we have second topic for Dr. Sheetal Raj, multiple comorbidities and polypharmacy in older adults. So the next day we are having Infinity Walk, Talk the Walk, the Pinnacle Stone List Churn, will be taken by Professor Dr. Vijay Selvan Nadarajan, and urinary incontinence in older women will be taken by Dr. Rajisha. And need of scope and geriatric physiotherapy will be taken by Anila Paul, and geroscience will be taken by Shyam Krishnan sir. So we all are eagerly waiting along with Makesh Babu sir and his faculties of Sree Anjaneya Paramedical College, Medical and Sciences, and with all our dignitaries and participants. Over to Arunima.
So may I continue?
Yes, madam, please. Please take.
Thank you, Chandramohan sir, for allowing me on this stage. I'm really feeling delighted to welcome the chairperson of the very first topic of the scientific session, Dr. P. Satya, Associate Professor and Head, Department of Kinesiotherapy and Physical Diagnosis, School of Physiotherapy, D.Y. Patel, deemed to be University, Nerul, Navi Mumbai, Maharashtra, India. Madam has experience of 18 long years and 2 months. She has done her PhD in physiotherapy in 2017 on effect of resistance training on selected motor fitness variables of male cricket players. In 2001, she achieved her master's degree in physiotherapy in orthopedics from JKK MMRF College of Physiotherapy, affiliated to the Tamil Nadu Dr. MGR Medical University, Chennai, India. Madam also achieved a postgraduate diploma in yoga in the year 2009 from Annamalai University, Tamil Nadu. During her service experience, Madam has taught students in many different colleges. She also have performed the duty of many administrative positions in different academia. Madam has 38 publications in various international and national journals with high impact factor. She also has attended 10 different conferences and 22 different workshops. Madam P. Satya, please.
Yeah, thank you for such a nice introduction of me. I'm happy to be part of this GERICON conference and to chair the first session, which is where we have a distinguished speaker, Sheetal Raj M., who will be speaking on comprehensive geriatric assessment. Ma'am is an associate professor in Department of Medicine from Kasturba Medical College, and she has done a lot of fellowship programs in geriatric medicine. Ma'am, it will be great, to attend your session because we are all aware of how to treat MSK conditions and neurological conditions and cardiopulmonary conditions. But geriatric physiotherapy, it needs a different angle of treatment approaches. So I think this conference and your presentation in this GERICON conference will give us an idea of how actually a therapist has to plan a program for geriatric patients who come every day to the physiotherapy clinic, and we have a lot of patients who come under geriatric category to our setup as well. So it will be nice, we will get a very good idea of how to assist them and go about with physiotherapy treatment. Yeah, you can just start your session.
Thank you, madam. Thank you for your kind introduction.
Yeah.
Can I share this?
Ma'am, please. Yes, ma'am.
I hope it's visible to all.
Yes, ma'am. Kindly go for the full screen view, please. Slideshow.
Please let me know and stop me if my voice or video becomes unclear.
Yeah, okay, ma'am. Your screen is completely visible. Please, with permission from chairperson, ma'am, you can start.
Thank you very much. So as madam had introduced, I think today what I will be talking right now is a topic called comprehensive geriatric assessment. So the usual assessment when we see any patient in our OPD is limited to a very specific disease-based or complaint-based focus. In comprehensive geriatric assessment, what I would like to tell you about is a process where we look at the patient as a whole and we don't look at a single complaint or a single acute event which has brought the patient to the hospital. We look at multidimensionally we look at the patient. So just for us to understand what are the key factors that we need to understand about an older person, we need to understand the concept of intrinsic capacity. So intrinsic capacity is what WHO defines as the combination of an individual's physical, mental, including psychological capacities. If you can see the graphic here, this together is what makes up intrinsic capacity. It includes sensory capacities such as vision and hearing. It also includes cognitive capacity in that the patient be able to understand and interact with the environment around them, psychological capacity, locomotor capacity, and vitality, which refers to the nutritional elements of an older adult. So the functional ability is described as the combination and interaction of this intrinsic capacity with the environment in which a patient or a person inhabits. So basically what we understand from this is that a person who is functionally capable should be able to do things that they consider important to themselves. So when we use the word what they value, what we understand here is a very individualized idea. It's something that a person considers important and sacred to himself. It is necessary for a person to meet their basic needs, to learn, grow, and make decisions, to be able to roam around, to be able to be mobile, to build and maintain relationships, and to contribute to society. So if you see, this does not limit itself to physical disease. Here we also look at emotional factors, psychological factors, even to the extent that the patient needs to have a sense of purpose in their lives. And it is all of this together which is known as functional ability. And the process of developing and maintaining this functional ability is what ensures well-being in older age. And the goal of every team of geriatricians or interdisciplinary providers in a geriatric team will be to maintain and provide this functional ability to each of this patient. So what differs in geriatric assessment versus a usual assessment? Now I would mention this primarily from the point of view of a physician, but also of any other provider, as I see that many of you are from specific areas of specialization. Usual medical care deals with disease-based assessment as a disease-based assessment and management. So here, what we look at usually is the complaint the patient has come with, and we try to solve that. Whereas in geriatric assessment, we recognize the presence of geriatric syndromes. And I think in today's session, you will be looking at many of these syndromes in detail so as to understand what implications they have. So in a geriatric assessment, it is routine to screen for geriatric syndromes. Some of these syndromes have special mention here, multimorbidity and polypharmacy. We will be hearing about it in my second session. Frailty, deprescribing, which is a solution or a management technique for polypharmacy, and functional assessment. So it is important here that we assess how the patient functions in his environment and his geriatric syndromes that are present in a given patient. And this is over and above the acute presentations that they come to us with. So geriatric assessment basically is a multidisciplinary diagnostic and treatment process. So remember, this is not just assessment. The word comprehensive geriatric assessment includes creating a goal and a care plan for the patient. It aims to identify medical, psychosocial, and functional capabilities of an older adult in order to develop a coordinated plan to maximize the overall health with aging. It is usually done by a geriatrician alone or by a multidisciplinary team. So usually a comprehensive geriatric assessment team can include, apart from a doctor, it can include a nurse, a medical social worker, a physiotherapist, and in some teams, if the resources permit, you could even have a dietitian, an occupational therapist, a clinical psychologist, and similarly a few other branches such as a clinical pharmacist who have become key members of geriatric teams today. And because, as I started in the introduction, as I told you, there is always the problem of access. The most difficult or the greatest challenge to geriatrics today is the availability of trained manpower. So most of geriatric teams are made up of available professionals, and whoever is the lead in that team can become a head for the team and can take the rest of the team forward. So there is no rule that there needs to be a doctor who leads this team. A physiotherapist could be the leader of a geriatric care team and could build the rest of the resources around himself or herself. So remember that comprehensive geriatric assessment is the term that is used for a geriatric assessment process which involves a treatment care plan, and it is multidimensional and multidisciplinary in nature. Multidimensional because it includes not just physical capacity, it also takes into account cognition, psychological well-being, and the interaction of patient with their environment in a functional capacity. This is a question I would like to ask the audience, if anybody would like to answer. Whom would you like to do a comprehensive geriatric assessment for? Who are your ideal patients? Whom do you want to do this on? Is it an 80-year-old man who has intractable heart failure, got lost on his way home, has advanced dementia, or is having a terminal cancer? Would anybody like to attempt answering this? You can tell the
Yes,
answers
madam.
or put them in the chat.
I request Rupesh to check our YouTube chat live. Duna madam, you can check any messages.
Answer to,
Yes, sir.
answer to option 2, it got lost on his way.
You would like to perform a comprehensive geriatric assessment in an 80-year-old man who
Yashital ma'am, Arun sir has replied to you. Kindly listen to him. Arun sir, can you please tell me once?
Answer 2, ma'am, got lost on his way.
Got lost on his way home. Answer 2. Any other answers? So would you like to tell us why you chose that answer?
Maybe dementia or Alzheimer's may be there, so we need some comprehensive
possibly
assessment.
have dementia.
No, you would perform a comprehensive geriatric assessment. It is what you have.
Sorry, sir, could you speak up?
No, yeah. Can I tell the answer?
Yes, sure.
As advanced dementia.
As advanced.
The third one is has advanced dementia.
Okay. Any other answers?
Ma'am, other conditions, intractable heart failure and terminal cancer also needs, but they are these specific treatment they are needed. But like dementia or they got lost on his way home means comprehensive
assessment.
Can anyone tell me why actually option 2 and 3 both refer to dementia in some form? So can anyone tell me which would be a better answer? Why there are two similar answers?
Maybe the third one is advanced dementia would be the right answer. The thing is, we need to know the functionality of the resident or functionality of the old folk, whether it is mobile or no, we need to know that. So then only we can go to the answer of God, last is a way home.
Arun sir, any reason why you chose yours over 3?
Like when the elderly patient got lost, his way home is very difficult to find him back. So we need to give a comprehensive assessment, or we need to do a comprehensive assessment as well as treatment for the patient who are not able to identify his residence or his place where he lives. So he maybe have advanced stage of dementia also.
Okay,
That's what I
so
thought,
actually the answer is option 2. And the reason is, ideally a comprehensive geriatric assessment is done for a person who has some degree of potential for significant improvement in function. If you look at option 1 and 3 and also option 4, they are more candidates for palliative care than for geriatric care. So when I say the word palliative care, what we are looking at is that we are looking at a terminal event where the patient has already hit the maximum point of his illness. Whereas if you look at a person who got lost on his way home, this is a very early stage of dementia where a comprehensive geriatric assessment, if done, can actually alter the course of his progression and can create an improved quality of life. Whereas if you see option 1, 3 and 4, all are patients who have advanced to a stage of disease where further improvement in the medical progression is very less likely. And most of the treatment goals will focus here on improving their quality of life for the remaining years that they live, rather than to actually give them a change in their functional capacity. So this brings us to who needs a comprehensive geriatric assessment. Do we need to do this in all older people? Does everybody above the age of 60 require a comprehensive geriatric assessment? So there are some indications which I have pulled from various resources. This is not an absolute list, but it's something that as providers we can keep in mind when we see an older person and we think about, does this person need a comprehensive assessment? One is a person who develops a newly worsened health status or when a new risk factor is discovered. So this is a person who's been living a stable existence up to a point and say has got a new diagnosis of a malignancy or of a hospital admission, which has caused a sudden change in their otherwise stable or steady functional capacity. So a newly worsened health status is one that can trigger the need for a comprehensive assessment. Anybody with an age more than 75 years. So even if the person has no other complaints, the age alone becomes a factor only at extremes of age. So anybody above 75 becomes an automatic patient who needs a comprehensive assessment. Anybody who is functionally impaired in the form that their activities of daily living or instrumental activities of daily living require help as told by the caregiver. Person who lives alone. So here we recognize that social support is a very key factor in deciding the need for comprehensive assessment. A person who lives alone is always at a greater disability, even though the physical capacity may be intact. The absence of a social support system puts him at a higher risk, and hence that person would require a comprehensive assessment. Somebody with a history of falls, delirium or confusion, person who is not able to cognitively interact normally, incontinence. So these are all referring to the various geriatric syndromes which are obviously present. More than 2 admissions to an acute care hospital per year. So this is how we often get our patients in our OPD, where somebody who has been absolutely fine, have been living a normal life and has an acute event, say a pneumonia or a urinary infection, has been admitted to the hospital, and then they developed another complication which led to a second admission. At the end of this, the family feels the person is not himself. They are not able to carry out the earlier activities. There's need for a very high, there is a high caregiver burden at home. in the form of any of the geriatric syndromes, which you will be hearing over the next few sessions. So more than 2 admissions in a year becomes a reason in itself, and failure to thrive. So failure to thrive is a combination of nutritional disability and and functional incapacity, which combines to make the patient very much frail and difficult to survive in his environment. So these are some of the factors which, if are present, indicate the need for a comprehensive geriatric assessment. So it tells us that basically, if I had to summarize this in one term, what I would say is a person who is completely fit and living a very active life does not require a comprehensive geriatric assessment. Also, a person who is extremely sick and bedridden also does not require a comprehensive geriatric assessment. So a CGA is indicated specifically for those who are in that middle range, who will benefit greatly. That is where we can provide the maximum amount of gain for the patient, is the person who is moderately fit but has developed some sort of a change because of any of the factors that I have listed here. So this brings us to the answer to that question, that a person who is absolutely bedridden or immobile or sick or in an advanced stage of their illness will not benefit much from a comprehensive geriatric assessment. And remember, when I say this, I do not mean that they don't need physiotherapy. What I'm telling you is they do not need a comprehensive geriatric assessment, which is a very specific process which is conducted by a geriatric team to identify factors which can be corrected. So if I had to again summarize this patient in the words of Atul Gawande, this is a beautiful book, Being Mortal, to anybody who is interested in geriatrics. This book actually summarizes beautifully the problems of being old, the solutions that can be tried, and it is an experiment by the United States mostly, and more of the Western perception, but it's written by an American Indian. So it's very useful to understand the problems of geriatrics and to give us a perspective on what can be done for older people in our context. So he says the old croc, he refers to this geriatric patient as the old croc, as someone who is slow and difficult. So the old croc is deaf, he has poor vision. The old croc's memory may be impaired. So you visualize this in the form of an older person trying to navigate our complex healthcare system. He comes to the medical OPD, and this is how they are. They have to, with the old croc, you have to slow down because he asks you to repeat what you're saying or asking. The old croc does not have one chief complaint, they have 15 chief complaints. How in the world are you going to handle them? You are overwhelmed, and he has high blood pressure. He also has diabetes. So this is a typical older person who comes to the medical OPD with a wide list of complaints. He needs to meet multiple doctors. Most of the doctors feel that he is such a problematic patient. It takes such a long time to sort his problems. And very often at the end of all these problems, the patient remains highly dissatisfied. So this is the kind of patient who requires to be taken for a comprehensive geriatric assessment where all elements of their problems are looked at. And when I say, I would use the word problems, not chief complaints, because the patient has so many chief complaints. We look at that as a problem, the difficulty in reaching a bathroom, or the difficulty in the patient taking food to the mouth, or to be able to see the medicines that he is taking. So we cannot call this as cataract or refractory error. This is a problem that the patient faces. And in CGA, we look at disease from a patient perspective and not from a medical or a technical perspective, which we are otherwise used to. So if you look at this graphic, it kind of tells us who these patients are. So these different colors denote patients with specific diseases. So they are patients with high blood pressure, with dementia, with heart disease. And in the center here, what you see is this center cohort, which is an overlapping cohort. These patients have everything. They have high blood pressure, they have dementia, they have heart disease. And this is actually what we call as multiple comorbidities. And these are the patients who have the maximum problems in our hospitals. They are the ones who come with the maximum number of complaints, and they need the most attention. And they are the patients whom we look at who need a comprehensive geriatric assessment. So what's the point of doing this? How does this geriatric assessment help the patient? So primarily we give them time and we do a multi-dimensional assessment. So we are not limiting ourselves to giving a medical prescription and leaving it at that. We look at all aspects of care. What it does for the patient is that it decreases long-term home placement. So this language is actually from a Western or from the developed world, where a person who is not able to look after himself ends up getting placed in a nursing home or an old age home as we know it, where they are given care 24 hours by a designated caregiver. So the idea of doing a geriatric assessment is that it allows the patient to be independent for the longest time possible. If you ask any older person, something that they always tell as a wish or as a goal for themselves is that I wish I do not have to depend on anybody during the last stages of my life. So a geriatric assessment primarily aims to achieve that goal. It minimizes the impact of geriatric syndromes. So things like memory loss, incontinence, and falls, although to a cursory assessment or a physician might appear like something which cannot be solved, with the help of an interdisciplinary team and doing a CGA, it becomes significantly minimized. And one of the great benefits in geriatric care is, I'm sure all of you who work with older people would have experienced, is that a slight change in any one of the geriatric syndromes actually gives a great benefit in functional ability for the patient. They feel so much better even if you modify one small problem of theirs. So it minimizes the impact of geriatric syndromes. It enhances health and functional outcomes. It reduces readmissions to the hospital. So many a time, things like inappropriate drug use or the tendency to fall due to correctable factors are what brings patients to the hospital. If you analyze readmission rates in hospitals, most of them can be prevented. Most of them are due to preventable causes. So identifying these patients who have complex needs and doing a CGA will actually help us to bring down the readmissions and bring down the burden of care for the geriatric population. It also helps us to facilitate effective discharge planning. Knowing what is the environment the patient is going into and identifying the patient's geriatric syndromes will help us to better prepare the patient for a discharge rather than to just discharge from hospital where the patient finds himself grossly unfit or unsuitable to be living at home, which leads to a catastrophic event such as a fall, bringing in a second admission or multiple readmissions, which could all be avoided if they underwent a CGA at an appropriate time. So what is the CGA? And I'll just give you in a little brief what extra is done apart from medical assessment in a CGA. So the usual medicine assessment is done by the physician and by the healthcare team. In addition, a few things which are to be noted is, in an older person, usually communication has to be taken care of. We need to be aware that the patient may not be able to hear us. So ensure that the patient can hear, slow the pace of history taking, take a collateral history, ask about functional independence. So this is your activities of daily living, and take a full drug history. In addition to this, we also look at social support systems, as I've been saying earlier. Find out who the patient is living with, whether they have a family member or a caregiver who is willing to help them in times of need, whether they have a social network. It could be a church support group, or it could be a nearby community which is helping them. Find out their activities of daily living, to what extent is the patient independent or not. What about medical examination? Apart from the usual medical care, a key role is given to examining the following things. Look at the skin, check for the sensory function. Vision and hearing have a key role to play. Postural hypotension, a very common cause for geriatric syndromes, especially falls. Look at their teeth, look at their joints, do a per-rectal examination. Functional status assessment, cognitive assessment, assessing gait and balance, incontinence, nutrition, hearing, and vision. So many of these geriatric functions or geriatric syndromes will be taken for in today's session. So I will not go into details of what these components are. But in a geriatric assessment, remember that all of these will be assessed as a screening tool and initially, and if found to be impaired, there will be a detailed assessment done, at the end of which the patient is usually assessed also for the geriatric syndromes. So memory loss, depression, incontinence, and falls, these are the very common geriatric syndromes, and they are always looked for in a geriatric assessment. So once you do all this is when you get an idea regarding the actual deficit profile. following which a care plan is made to solve these problems, and the patient is put on a goal-based treatment regimen, which includes all of these factors. So looking at this, just a basic activities of daily living, I'm sure all of you are very familiar with this. So remember, these are basic, they are not related to the culture or socioeconomic status, and loss of these indicates severe dependence. Whereas instrumental activities of daily living, these are more of a screening test for us to understand who needs a geriatric assessment. Patients who have lost their IADLs usually are the ones who need a CGA. And some of it, as you well are aware, dependent on culture and socioeconomic status. So the ability of a patient to do any of these tests is assessed. I have posted here a few other screening tools. These are done depending on your need. So this is listed under rapid geriatric assessment. One of the problems with geriatric assessment is that it takes a long time. It takes 2 to 3 hours to do a complete assessment. So some of these screens given below, such as a simplified nutritional assessment questionnaire or a rapid cognitive screening, these are useful in on an outpatient basis when you want to do a rapid assessment and you do not have much time. But a detailed assessment will depend based on whatever findings that you get. And there are various screening documents which are dependent on the on your institution. We have an assessment tool in our institution which we have based on the WHO document for comprehensive geriatric assessment, and you could choose any of these documents for assessment. And as I told earlier, any member of the team could be a lead in doing the assessment, at the end of which is the patient is provided with a care plan, and that is then executed over the next few weeks. So with this, I would like to end my session, and I think we can take any questions, doubts, or discuss anything if required.
Is there any questions?
Sir, ma'am, I have got a question in YouTube, just forwarding in the chat box. Will live, he or she asked, ma'am, any books for reference and guidelines of geriatric physiotherapy in form of palliative care management?
I can refer you to medical books. Physiotherapy, I think I would, if Shyam is there, medical books are there for reference.
Yes, madam. Later we would inquire regarding this to Shyam sir, and we will post in our WhatsApp group, mainly for these GERICON participants.
No more questions yet in YouTube, sir.
I would like to just say one point, is that there is this, again, I think Shyam would be the better person to tell you, there is this ACSM guidelines for older adults for geriatrics, which I think is the reference point for most of the physiotherapeutic treatment that is being given as prescriptions most of the time. Again, it's not my specialty, but so I think I will refer to Shyam. And one more point I would like to make is that geriatrics and palliative care are very closely intertwined specialties, where patients merge from having geriatric needs to having palliative care needs. So it would be useful for those of you who are interested in geriatrics to train yourselves in both these branches. And I find it extremely enriching to know palliative care when I am treating geriatric patients. It helps a lot. And I can refer you to sources, medical sources for both, but specific to physiotherapy, I think I'll refer to Shyam.
Yes, madam. And we have Arun Balasubramaniam sir also, Vijay Kumar sir also. If you know any books also, you can refer to us so that people will come to know any
Vijay
ideas.
Kumar sir referred a book in chat box. Chandramohan sir, kindly please say the name.
Geriatric Rehab by Guccion. Guccion is a good book referred by Vijay Kumar sir. Thank you, Vijay Kumar sir. Any questions from our dignitaries and delegates?
Sir, a few questions have come in YouTube. I will be forwarding.
Yes, I request Satya Group Sat madam to go through the chat box and handle the session, madam. Please.
I will be posting the questions, ma'am.
Yeah.
Yes, ma'am. Post it. Kindly check.
So one of your question is, when does an patient need to be institutionalized? Elderly patient, which is by, yeah. When does an elderly patient need to be institutionalized? That's the question which is put up by Shreya KG.
So actually, we do not have a rule in India. We don't have guidelines here. Most of the guidelines we refer to or look at are Western, where the government mandates that when a person is incapable of looking after themselves, they have what is called hospice guidelines, where patients' institutionalization is determined based on their ability to independently look after themselves. It's also based on the social support systems which are available to them. So in India, we do not actually have this, but on a practical level, I would like to say that older patients, usually the need is evident in patients who have advanced dementia. They are the ones whom the family finds most difficult to care for at home, and they are the ones who end up often aggressive, or who have behavioral problems and psychological problems, which makes it very difficult even in an early stage of disease where these problems are predominant. They end up requiring some sort of institutional care, whereas the other diseases, even if the need is higher, the question, do they need to be institutionalized, is I think more a social and cultural question in India, because a lot of geriatric care in India is provided at home by the family, and it's often by informal caregivers. Usually the caregiver ends up losing their job, or and being unable to work because of this disability of one family member. So we do not have a criteria per se, but it depends on the degree of social support that's available, and also the availability of institutions to take care of such patients. And I would also say that in lots of cases, it is not socially, culturally acceptable to institutionalize patients. So it's a difficult answer in an Indian context. But the common requirement which patients come to us for is mostly dementia, because most of the other ailments, provided if we are able to provide a home care in the form of nursing or physiotherapy, the patient tends to remain within the family until the end of life, provided the financial and other social support systems agree for maintaining such a system.
Ma'am, there is one more question. So they have asked for, can you suggest any risk assessment scale, fall risk assessment scale?
Yeah, again,
So
I think most of our physiotherapists would be familiar with the scales that are available. I think something has been put there, Morse fall scale. What I refer to is not a detailed fall risk assessment. If you see, what I work in an interdisciplinary team where we look at screening for falls, after which the physiotherapist takes over to do detailed fall risk assessment. So what I refer to is the WHO, there's a document called the Integrated Care for Older Persons, which gives basic assessment tools for all components of the intrinsic capacity, where we screen for fall risk, and once fall risk is done, there's a detailed assessment protocol given under that. It goes by the name ICOPE, ICOPE. It's a document which can be used by all or any interdisciplinary team to initiate a fall risk program. But a detailed assessment would require, I think, specific knowledge, which again, I would say is not my profile.
Yes,
to answer.
madam. We have a topic, madam, on falls,
Yeah,
violence and falls, and he will be covering it. Yes, madam. Satya, madam. Any
Yes,
other
sir.
questions, madam?
Again, it's based on the scales. Many questions are based on the scale. Any geriatric scale which can be used.
Yes, we will be having.
Yeah, for the geriatric population, this is what I would refer you to. There's a WHO document called ICOPE, which refers not just for falls. It has basic scales for all components of a geriatric assessment in the form of readily usable algorithms, which if you can use for your team, if you have a nurse or a social worker on your team, they can be trained to use it. Any trained healthcare provider can use a combination of these scales to initiate a geriatric assessment, following which specific deficits can be addressed by individual specialists, say a physiotherapist or a clinical psychologist, based on what is identified.
Okay. I think that's it, ma'am. There are no more questions. The questions are mainly based on the scales.
Yeah, I think we'll have a separate session, so
yeah,
that can be answered there.
Yeah, it's really the session of yours was really enlightening, where a few points like it is a multidisciplinary assessment where the memory, the vision, the incontinence, fall, everything has to be considered when we are assessing a geriatric patient. And it's also nice to know that rapid geriatric assessment scale can be used in OPD basis to, form a group of these geriatric people and give them proper treatment program. Yeah, I think your session was really good and it was wonderful.
Thank you, ma'am. Thank you very much.
Thank you so much. Yes.
Thank you so much, Dr. Sheetalraj M. Madam, for this very knowledgeable session. And I would really like to thank Dr. P. Satya Madam too for making this topic more interesting to the participants by chairing in it. Now I would like to request, thank you, ma'am. Now I would like to request Mrs. Aroma Madam to carry on with the next topic, please.
Before we move on to the next topic, we would like to invite Vijay Kumar sir, kindly make announcement for this.
Oh, okay. It's now my privilege to introduce Dr. I am Vijay Kumar sir. Currently, he is working as a principal at Dayananda Sagar College of Physiotherapy, Bangalore, India. Sir has secured PhD, MSPT, FDSR from London, and he is a certified in bioethics from UNESCO. With the long list of his achievements and glory, I would like to invite Dr. M. Vijay Kumar sir. Welcome to you, sir.
Yeah, thank you. Thank you very much, ma'am.
Thank you.
I'm quite privileged and obliged to be part of GERICON 2021, and I would appreciate the organizers. I would appreciate the organizers for taking this unique theme, keeping in front. It has been long awaited for so many professionals. Because usually there used to be a conference that's happening on a common platform. Now it's good to see that the profession is going down, trying to impose its knowledge on specific and specialty areas. And recently, we have been working a lot of conferences on manual therapy, sports, and orthopedics and neurology. Now, sub-specialization is going into geriatric, I think the first one. So my first congratulations and appreciations to the people who got this idea about this GERICON, focusing only on geriatric assessment and rehabilitation, which is a need of the heart, because like I know, India is growing up with elderly populations with increase in life expectancy rates, and the amount of geriatrics we have is steadily growing up, and we don't have a proper guideline or information how they can be accommodated for a better and healthy and a happy living in the society. So my appreciation goes to the people who have got this ideology and the people who have come down to support those individuals who got the idea to get into a particular common platform as a conference, discuss on the rehab component of geriatrics in special. So congrats and appreciation to the team, the IT team, and all the people who have been supportingly working for this GERICON 2021, inclusive of the speakers, very eminent list of speakers, the chairpersons, other people who are providing us inputs. And good to see there are a lot of papers that has come down to in the list as presentations. So I'm really glad that the profession is gaining more and more deeper and focused area of work. This shows that we are definitely growing up, and this shows that we are definitely moving towards something which is found to be unexpectedly in the past 20 years, and we are growing heaps and bounds, and we are expected, and we hope that this particular sub-specialization and branches of rehabilitation part takes up a lot of interest and inputs from the student side and the community, that at the end we stand as an independent, strong, and self-dependent profession, and we'll be able to gain and give to the society the best we can do it up. So congrats and all the best. I wish everybody the best of success, and success prevails as there is a long hard work that's being there with you. Good, keep going.
Thank you, sir. Thank you for your deep knowledge with us, sharing your deep knowledge with us. Now I call upon Ms. Arnima to take care of the session. Arnima.
Thank you, ma'am. With all respect and gratitude, I take this opportunity to introduce our second chairperson, Professor Dr. L. Gladson-Jose, Principal, Dr. M.V. Shetty College of Physiotherapy, Mangalore, India. Professor Dr. Gladson-Jose possesses 20 years of experience in teaching and administration. He has done his MSc, MPhil in psychology and completed his PhD in psychophysiotherapy. He has served as a Board of Studies member in physiotherapy and also an expert committee member for BPT and MPT syllabus committee under the Tamil Nadu Dr. MGR Medical University, Chennai. Sir has been awarded the Best Teacher Award from the Tamil Nadu Dr. MGR Medical University, Chennai in 2020. Sir has been honored by Rajiv Gandhi University of Health Sciences, Bangalore as an eminent teacher in physiotherapy in 2020. He has been the task force member of National Model of Curriculum of Physiotherapy under the NIAHS Ministry of Health Care and Family Welfare, New Delhi. We are so privileged to have you here, sir, to grace this event and host the session with our second resource person, Dr. Vinil Pillai. Over to you, sir.
Thank you for your introduction. I'm very happy to introduce Dr. Vinil Pillai, MSPT. He is the senior physiotherapist, worked in UK, NHS, and the inpatient services he has done. And presently he is in Neurospinal Hospital, Dubai, UAE. Sir is having about 25 years of work experience across the NHS, UK, India, and UAE. Talks locally and internationally on spine related conditions, mainly the cervical area he is very much interested, lumbar area he is interested, and at the whole back he is very much interested, and he has done so much of work over these areas and all. And today he is going to talk about the physiotherapy in surgical and non-surgical spine. It is very, very important topic, because when we were there in the CMC Vellore, where we have seen so many patients, and the Bagayam, which is very much famous for the spinal problems and all. Then the Paraplegic Foundation that is in Mumbai, it is very, very good to see the patients over there with the spinal cord injury and all. So sir is very much interested in this aspect, and we are very happy to have you here today. And being the line supervisor, which is there in the higher post, you are there to provide so many employment to the coming forth the students also. You are the example and role model for so many physiotherapists. Being the senior physiotherapist, you know about the Tamil Nadu, Rajiv Gandhi University in Karnataka, and the different hospitals in India also. And you know well about Canada and the UK as well as Dubai. So you are the overall champion who roam around the different countries and proclaim the physiotherapy profession to all the people, and you have done a wonderful job in treating patients too. I have seen so many appreciations for you in the charts which has been given by the reviews of your hospital. Thank you very much, sir, for being here today to present the topic on physiotherapy in surgical and non-surgical spine. I welcome you, sir, on behalf of the organizing team. Over to you, sir.
Vinil Pillai, sir? Yes, Duna madam, allow Vinil Pillai sir to share the PPT.
Sure, sir.
Yes.
Vinil sir, kindly go for the full screen view. Sir, we cannot hear you. Kindly, can you be a bit louder?
Yeah, can you hear me now?
Very feeble voice, sir.
There.
Make it full screen.
Can you kindly take off the headphone and try without that?
Just one quick second.
Yes, sir. Yes, sir. Better now.
Yeah. Now we are good.
Yes, sir. Fine, sir.
Everything good? Okay. So you guys can hear me, you can see me. Is that okay now?
Yes, sir. Fine, sir.
Yeah, fine.
Please
All right.
continue.
Good. Right. Good morning to everyone in India and regards to everyone elsewhere around the world who are listening to us. And thank you so much for the. I mean, I'm completely flattered to listen to such a long introduction. Usually don't get that much, but yeah, thank you so much for that, Gladstone. And the earlier speakers, it was Dr. Sheetal. I think she went in so much detail that now I am a little bit overwhelmed that my topic might not be that that detailed. Anyway, I'm just quickly introduce you to myself. My name is Binal, and I'm a clinical supervisor. I supervise our team of physios and intern physios in our predominantly spine surgical hospital. And we've been there for the last 15, 20 years doing the same. Now, coming to the topic, when I was introduced to this, when we discuss aging and aging spine, first of all, before I start with my my PowerPoint, so something which we need to understand is what is aging. People generally think aging is a chronological number. Yet you're born, you have a date of birth, and then you go ahead every year, you celebrate your birthday, and that's called aging. But that is not the fact. The fact is aging is something like you have an inbuilt battery and your battery is getting drained off. It's a simple word of using what is aging. In a very technical way, we would say it is how your DNA is getting oxidized or your cells are dying and replenishing. If you look at a larger picture, we would say that how is your tissues or how is your systems? Each system is surviving as the days progress. So any one system fails, it starts to actually begin an event of chronologies, which is what aging is. Now, dealing with aging, we call them senior citizens here. We no longer call it Department of Geriatrics or old age people. We don't use that word. I don't know about elsewhere in the world, but nowadays we just use it one common word, especially here. It's called Senior Citizen Center or Senior Citizens. In fact, even they make it Senior Citizens Happiness Center as a new word for older term of old age home. So it just creates some sort of positivity. So that is just an introduction. So let's get on with our topic. My topic would be aging spine and a surgical spine. So what we will try to do in two halves is just to give you a basic introduction on what spine and aging spine is, how to deal with it, especially how to deal with people who are elderly. This is what the topic is, and what is my experience or our team experience, and just going to share all that with you. Right, so start with the first slide. Mainly, let's just jump straight into what are the clinical disorders of spine, and most common 5. I'm just taking up 5. I'm sure you can find many more on the internet or your books, but most common ones which we see. Number 1 is spinal stenosis. Stenosis is when you have narrowing of the spinal canal, which you all know. The canal gets additional deposits either by fat or thick ligaments, or the whole surface becomes more harder, which starts to squeeze in the whole network of nerves which are going down, which is known as the canal. And what happens is your patient generally complains that they can't stand or walk for a long time. They have what is known as claudications, and they need to sit or bend forward. So number 1 on the list would be stenosis. Number 2, osteoporosis or metastatic. Metastatic would be anything like myelomas, which is more common. Osteoporosis is very predominantly common in this part of the world. It would be really amazing to know. I mean, it is strange to know with all that sunlight and vitamin D and stuff, but still, seldom patients go out and be in the sun. So what happens is we have depletion, and they do have osteoporosis. Osteoporosis, randomly check, very common. And most common thing with the compression fractures, again, is osteoporosis. And less often you would see metastatic compressions, usually from myeloma. Less often we don't see so much, but I'm sure in India we used to see a lot of tuberculosis of spine. So yes, so these two things come in the next. After which you would have lesthesis, your degenerative spondylolisthesis, which is when one vertebrae moves forward or backwards onto the other one, and that creates a great amount of instability. Just to quickly tell you one by one, so what am I looking at in each condition? For number 2, I just sort of missed that somehow. It's just when osteoporotic or any compression fractures is very localized pain. Most common sites are usually in mid to lower thoracic, and patients generally just have an history. If you take a subjective history, they really have a strong history of either a fall or a jump or some sort of a uncomfortable ride or a sudden cough or sneeze which actually created this, or a lifting weight. So there is a clear history which has led to some sort of a compression fracture. Number 3, the spondylolisthesis, which is the term that I have used with instability. This would come more with when patients come to you, they say, they sit for some time, and when they get up, they have a lot of pain. It just creates that anatomical instability, and then they start moving and they feel better. So then you really need to start thinking something is happening in terms of the movement of that particular vertebral body or the spine. Number 4, which is more straightforward, which is the adult scoliosis or kyphosis, which is something which you have to actually see and observe for the spinal contour. Have a look at how the patient is, and your general postural assessment, which will give you a clear picture if they have any sort of scoliotic changes or kyphotic changes, which may require or may not require additional radiographic assessments. The thing is, now with scoliosis, as a manual therapist, this is again my area of interest also, is that we have something known as facet ankylosing. Less often, we don't see so much, but in India, I've seen the days that we used to work, we used to see a lot of ankylosing spondylitis, the AS cases. I'm not going to go in detail to all that, but something which really works is you need to assess the facet joints, and that is where you have to get these patients to do to check their side flexions and rotations and extensions. Then you have a better understanding if the facet is really maybe the reason of pain rather than the actual scoliosis, and just for an information. And then, of course, the last but not least is degenerative disc disease, the DDDs, which is a very common thing, and as part of wear and tear as you get older, any part of your body which is load bearing, that is anything against the gravity, is going to have some sort of degenerative changes. Let that be your knee joint or your back or your hip. So that is degeneration. So if you see the picture on your right, so you can actually see this is just a very nice picture which we were using it for our teaching purpose. So there you go, you have annular tear. This is just the disc, annular tear, and the tear, and then you have a small bulge. Further, you have a complete herniation, so you're definitely there, you're hitting the nerve roots. And then you come down, you can see the changes on the end plates. These are end plates, and these are end plates which are really going. So these are end plates. This is just showing you some sort of changes in terms of the bony structure. Normal aging, this is just for reference how the spine is. You have the basic anatomy of spine. The spine has, you see the curves, you have the first C curve, then you have the thoracic curve, you have the lumbar curve, the predominant 3 curves, and then you just have to keep looking at what is happening. It's most interesting thing is what's happening is if you just look at the thoracic spine and how it starts to move forward. Yeah. So if you just look at that, it just gives you an idea. It's just a reference for you. Jump. Hello. Okay. So.
Yes, sir. Sorry for the trouble.
Yeah.
I request Duma Madam to check mics. And also I request all our dignitaries to keep their mic mute, please. Yes, sir. Sorry for the trouble.
No problem. Just thought somebody is going to ask me a question. Okay. When we come to assessment, especially, I mean, I'm not really keen to differentiate too much with aging population to non-aging population, or would you say elderly or geriatric to young, because the whole understanding of someone elderly is changed. We get patients who have surgeries on the spine who are in 20s and who are in 80s. And if you look at a decade back, if I would see myself assessing a patient before, I would see them, most of the surgical patients were only in the 50s plus, but this has changed a lot. The same comes to non-surgical. I have back pain patients or neck pain patients who are from right over 14, 15 years old, teenagers, and all the way up to 75, 80-year-old. The thing is, the 70-year-olds now are far more active physically. Most of them are working, and they want to continue their life working. So it's a tough call when you say that, oh, I need to assess patient on basis of age. I would rather assess them in basis of their system. So that gives me a better understanding. So if you actually ask me, what is your system age, that makes more sense than what is your chronological age. I don't know. I'm just raising some eyebrows, but may be wrong. This is just my thought. So come back to the assessment. If I do an assessment, I want to assess three major components: neural versus skeletal versus myofascial. So when I assess these three, and then I need to figure out which of these three is, for me, the criteria of treatment and where the problem lies. So when we go neural system, I would want to know how the spine, how the nerves are. So when I go into the spine, you just need to know how exactly the spine is moving, the movement on the spine, active and passive ranges. How is it feeling on okay. Somebody asking me a question? Hello?
Sorry, sir. I request dignitaries, please always look for the mic mute.
Okay. Right. Okay. No problem. Okay. So we'll come back to the neural system. So spinal cord and spinal nerves, basically the peripheral nerves coming out of the spine. So you just need to assess them. This is basic stuff. What I was just saying is, with the spine, you need to assess the spine in terms of the range. I'm just going superficially. I'm just going. If you have any questions, we'll deal with it later. So spinal cord, spine, go for it. Go for this active and passive ranges. Have a feel of the spine. There's nothing wrong in it. Check the nerves. You have to check myotomes and dermatomes. And of course, the nerve tension test is definitely on. Jump into myofascial system. So there's where you check only for muscles, or everything comes in. Spasms, your trigger points, what you think the superficial system, does that have or deep tissue system, whatever is having, you have to write that. You have to look for that. Again, the skeletal system, this would be purely into the joints. Again, you have to look at one joint above and one joint below. This is what we generally make it as a rule. So if you look at lumbar spine, you want to look at the hip joints and the thoracic spine, just to give a clear idea. Check for spine, check for joints, check for bones. Sorry, I just missed with the neural system before. So here is where the thing is with the range of motions. Just got a little bit distracted with that call. Sorry about that. So what do we do in assessment? We have a subjective versus objective. Early days when I was training and I was studying for my spine, my instructors would say 80% of your diagnosis would be complete with your proper subjective assessment, and then objective would be just markers. And we still follow the same thing. So aging people and senior citizens, what is difference between what I would do with other people? You need a subjective, you need to be very patient with the subjective, like the Dr. Sheetal mentioned earlier. You may have dementia along with it. You may have a lot of other issues that you have to deal with, hearing loss, speech issues, or so you may find it difficult. So this is where your subjective will be challenged, and you need a strong history taking, and you have to be patient. So subjective, you start with basic visual analog scale. So VAS, instead of asking them 0 to 10, ideally you want to just show them a picture with all the faces from showing you a pain pattern, which I'm sure all of you have in your clinics. When you go for pain, you need to know the sins of pain, we call it, the sins, the severity, the intensity, the nature, and what sort of pattern the pain is. And what I have seen in practice, whenever you get someone who are older, they would say pain everywhere. It's really hard to get this answer from them. When you ask where exactly the pain is, they say everywhere. So back, full back, from neck down to the whole lower back. So, but then you go in and dig it out one by one. So you actually need to palpate and say, okay, here is more than there. And then you need to localize and get it. The same goes with, ask them any time of the day is the pain, they say every time. And then you just need to, again, dig in a bit more. Ask them if you go out, see your friends, are you feeling better with the pain? Things like that. I'm just giving you some quick ideas. That gives us a better idea to understand. Now, and then, of course, your objective markers, like I said earlier, these are markers. These are things which give you a clear idea of progression. So you need your markers on motor. Yeah, you use your Oxford scale, your muscle testings. Sensory, you follow your dermatome path. We add in something which we use, what is known as DRAM. I mean, psychological assessment, you can use your zone depression scale or your modified somatic perception questionnaire. I use DRAM, which is the distress and risk assessment method. DRAM is straightforward, it's easier scale, and it gives us a clear idea if somebody is going through what we call as a yellow flag, depressed. And this gives us a very clear idea where to go ahead in terms of treatment. Last but not the least, probably the most important thing is quality of life. And there are many scales for this, but I generally use Barthel just to know how their ADL is and are they independent or not. And then you can further it up with other sorts of things like the McGill questionnaire with the pain along with the quality of life, just to know if they're having a good quality, they're able to do most of the things themselves, and is the quality of life good for them or not. Right. Okay, so jump in to differential diagnosis. Again, like I said, level up, level down. I'm just taking you quickly through one of our DMRIs, just for an understanding why it's important. This gentleman was complaining of back pain, but then he was fine. He's an 80-year-old gentleman. So if you see the arrow there, that's the L4, L5 is going into a spondylolisthesis, and you can very clearly see there that yes, it's come back and it's causing a lateral recess stenosis, and you can see the stenosis there. If you see this picture, and that probably a surgeon would take him for a surgery. But if you go in and check there, you go in the coronal image, you can see that these are the exit nerves, and these exit nerves are absolutely fine. So he did not. So there's no need of surgery. So what we did, we just continue with basic physio, start working on muscles and pain management, and he's absolutely fine. So differential diagnosis is extremely important, especially from the hip. And if you see over here, and the peripheral diseases. So these are top 4 differential diagnoses, which I always mention. Check for peripheral vascular diseases. They can cause and mimic pain, or pseudosciatica is something like a nerve pain. Peripheral neuropathy, elderly, you have diabetes. You may have uncontrolled diabetes or unknown diabetes also. They don't even know that they have diabetes, and they just have this. And then you have neuropathies, and it's peripheral. So you have to look at the SOC syndrome. You see bilateral below the knee, and you think this is not very common. It may not come from the back. It's actually from the peripheral nerves rather than from the back. And the hip, check for hip osteoarthritis, and trochanteric bursitis. Both can be palpable. Hip osteoarthritis, your patient, when you have hip osteoarthritis, would be more localized pain, and pain would be more only when he's loading that particular joint rather than both sides. So again, just to give you an insight, so differential diagnosis is very important, because in general, patients come to you with pain. When it's, again, the senior citizens, they don't like to go in for a lot of investigations. So what happens is they just go to the doctors or the GPs and say, look, I have pain. Just ask them, send me across to the physio. But they come to physio, probably you are their first-hand clinician, so you may need to do the differential assessment. So maybe your hands-on assessment can change the whole treatment pattern. Okay. So when do we plan for a treatment? How do we start, or where do we start from? Like the earlier speaker, Dr. Sheetal, when she mentioned, it's an interdisciplinary team, and this is extremely, extremely important that when we get a patient, we get them into the team approach. First thing we do is we get our occupational therapist on board and ask the occupational therapist to do a clear environmental, functional, most importantly, a cognitive status review for the patient. And if we have this, and then we go in, we do the false risk assessment. I'm sure later the speakers will go in detail. What we do, I'm just quickly mentioning it. False risk, we do a TNT quick screen. We do a screen with TNT balance. And if it gives me a high risk, I go ahead with the Morse and file it up. So he is on a false risk. And if we identify that, we just tag the patient as a high false risk patient. Like I said, team approach, and get on with the, we work together, and along with occupational therapists, we also have a social worker and a psychologist who works with us. So they bring in their own details with regards to assessments. When you start with the treatment of pain, functional bracing, this is the three major components, and functional restoration. This is our three key components of managing the senior citizens. So we just go through one by one. I'm sure all of you using this, and this is just again, like I said, just a superficial guideline. What do we do with pain? I would go with heat rather than cold. And generally, the older patients are not very happy. Though we use cryogun or cryopenguin, which is a deeper, it is a much more stronger cold therapy rather than the cold packs or something which is superficial. This is a nitrogen gas based, which has given good results, especially when it comes to spine and acute spine muscular pain. Heat, use it generally. I feel good. Yes, as we all know, put on heat, and it's a general yes, and patients feel better, and then it gives you it opens a window for you to go ahead if you want to do some manual work. TENS, I love TENS as a machine. I generally prescribe patients to take home and use it rather than come down to the clinic for TENS machine. So yeah, we give TENS machines to our patients either on loan or directly to buy and use it at home on a regular basis on where the pain is. Soft tissue releases, your deep tissue, soft tissue trigger points, acupressure, manual therapies, your mobilizations, everything is yes. We definitely go ahead with that. Generally, when we have the intern people coming in, they are a bit skeptical. They are a bit let's say afraid to go in because they think, oh, there is osteoporosis or there might be osteopenia, and should we do mobilization? Do we have problems? Yes, we have problems. We have in my past, I've seen like 6 or 7 patients who had chiropractic or what we do with the thrust techniques, and they had fractures, hairline, and this is mainly because they were severe osteoporotic and they were not checked for. So this is one of the things which you have to keep back of your mind. If you have, you're not just the senior citizens, even nowadays, even somebody at 30s and 40s are having severe osteoporosis. Like I said, in this part of the world, So yeah, so this is something which is very tricky. So if you are doing manual therapy and if you're doing thrust techniques, you need to be a bit cautious. Other electrotherapy things, ultrasound, general laser, taker is something new, and taker therapy is something which has come up recently, and it's not yet FDA approved. We don't have a full backup with regards to the publications, but still it is proving very good results. Taker was mostly used in sports and for soft tissue releases, and because it gives you a deeper heat. And with the patients, we have found it really good, especially if you have metal inside, because this is the only electro equipment which you can use with any metal inside. So there is no it does not interfere with any metal. So yeah, Taker therapy is we are using it since last year or two. We're still building up on our patient profile. It is providing great help for us. Shockwave, I love Shockwave. Shockwave is really good. Again, you have to know what you're using. Two types, radial and extracorporeal ones. Those who are using Shockwave units, they would know well. They are extremely useful, very good, provided you know what you're treating for. Trigger point, yeah, again, it's the same with soft tissue releases, trigger point release therapy, injections. Elsewhere in the world, you would see injections even done. So if you have musculoskeletal therapists, especially in the NHS, and they are licensed to do injections. Acupuncture, dry needling, very common. Done, not very clear with how much it is. I'm not an expert in that area, but I'm not going to give you any justification. Traction, I would not go with. There's no clear proof that it is effective. Nevertheless, some patients feel that it gives temporary relief, but yeah, it's not really a big. Okay, so we jump to functional bracing, something which you have to think about as physios, because on day one, if you think bracing is needed, it is needed. And if it is going to prevent further complications of any sort of activity, it is very much needed. Some of the most common things which we use, especially when you have vertebral fractures or hairline cracks, so you use the TLSO, the thoracolumbar orthosis, the tailor braces, duets, cash brace, molded jackets or corsets is very common. And yeah, so you have to make a clear judgment if the patient would be benefit from any of that. Okay, so functional restoration, what do we do? Functional restoration, the key areas, I mean, we'll go into this a bit more again. I'm just going to go through if this is a non-surgical cases. We try to go for global exercise program. Try to get them to do a bit of weight bearing, which is very important. Weight bearing especially onto the weight bearing joints, which helps to fire the muscles. Segmental training, those who are McKenzie oriented would really be aware of that, the method of mechanical diagnosis and therapy. Active stabilization with neutral spine concept. So we try not to push too much onto the spine, not too much of deep spine movement, rather than stick to more of flexibility, strength, and postural exercises. Manual therapy, like I mentioned earlier, soft tissue releases, spinal mobilizations, nerve mobilizations, definitely yes. A lot of neural flossings and glides, if needed, that is. And one of these pictures is our clinic here, this thing over here. I think you see it. This is called an aquasizer. So it's a water treadmill. So you fill the water up around the hip or waist area. So when you offload the weight, just in case the patients are in pain and they can't, so it really helps us to offload and to push them to go into a sort of a semi anti-gravity exercise program. And once the muscles are built up, then you can further it into a full gravity weight-bearing exercise program. So we have thankfully we have that as an option, which really helps us to get on with things. Other than that, definite is PNF breathing patterns, holds, breathing holds, excellent. Taping, again, taping, I know most of my colleagues are a big fan of taping. They do a lot of it. I would just keep myself on a hold with taping unless and until it is a definite need, because the skin, like the skin has to be assessed. And if you're not sure, this can cause a lot of issues in your practice, because when you are going to put in a kinesio tape at maybe even a 20-30% strength, it may be too much on the skin and may cause blisters, even at a proper a wound. So yeah, check the skin before you do it. Training on Swiss balls, we do a lot on Swiss ball TheraBands just to get the strength training. Something which we started more commonly is the spine school and group therapy program. The ergonomic program, so we just give them a whole lot. We could pull them all together and give them a weekend or once a bi-monthly program where they sort of meet each other and have a group therapy and work on the spine. Other things which we advise them, things like yoga is brilliant, Pilates, aqua therapy. You have additional places outside. They do aquarobics, aqua yoga, aqua therapy, so they can do that. Even water cycling things. Just a quick question is, there's something known as whole body vibration. It's called power plates and things, which, one of the things which they say is it really helps to build up bone tissue, but there is no evidence, and there is no increase in the body bone mass density. So there is no clear evidence. So if you are to tell them, there is no evidence. So just to let you guys know that. All right. So we finished the first part of non-surgical spine, and we just jump into the next area. This is the spine surgery, and this is what we do. This is what we do quite a lot. And amongst all these spine surgeries that we do, just putting it on most common thing is a vertebroplasty, which is just injecting into cement where there is a proper crack. Usually from the osteoporotic spine, you have open discectomies, microdiscectomies, laminotomy, laminectomy, hemilaminectomy, most commonly used for stenosis. And then you have with advanced stenosis, plus if you have unstable spine, then you have a lot of spinal fusion techniques. You have anterior lift, A-lift, P-lift, X-lift is extreme. It's all depending on which area you're going through. This is the anterior, this is posterior, this is extreme, this is lateral. And then you have the T-lift and D-lifts, which are more commonly not used. The T-lifts is, again, it is a posterior lateral, which is most commonly used, and X-lift, which is used now. A-lift is not so much because the approach is from the front, and it may cause a lot of anterior soft tissue and, all the organs, and chances at risk is higher. Interspace, spinal spaces, we're not using it so much now because I don't know how it is back there, but now we stopped using it. And this is just an overview of surgeries. And total disc replacements, most common, we stopped using it in lumbar spine. We're using only in cervical now. We do that in cervical. Elderly patients, not so much. This is more for someone who would be younger and gives a better results. Because this the total disc has to fuse, and it has to fuse properly, because if it doesn't fuse, then it gets moved, and then you have to keep on doing another surgery. So they just with somebody senior, they just go ahead with a proper fusion. Right. So I'll just go through this is just the predominant spine surgeries. I'm talking more of thoracolumbar, and just go with what exactly we do in spine surgery. So generally, we have spine surgical patients, and we try to get them in 1 to 2 weeks before surgery. So we see them as an outpatient. And ideally, that 2 weeks is now pushed up to 1 month. So we see them a month before surgery if it's a planned surgery. So what we do about the first month prior to surgery is work on them give them a clear instructions about what the procedure is, detailed assessment, especially motor sensory and all your areas with what exactly are they expecting after surgery, which is very important because with someone who's going in for spine surgery who has difficulty in walking or something and they're expecting a lot may not be very practical. So you just have to explain to them everything before surgery. So it makes our lives easier after surgery. We try to go one-to-one training onto their individual needs and education about exercise program, body mechanics, what things they should be careful before, and what generally how we can prepare them for after surgery. So assessment, again, the same as I mentioned before, the whole subjective, we show the pain patterns, and objective, the motor, sensory, and psychological. Like I said, we use DRAM. Other scales which we commonly use is Oswestry scale, the Japanese orthopedic scale. It's mostly used for cervical spine, the McGill-Page questionnaire, which is very commonly used. These are more commonly used especially when you have a failed back surgery syndrome, and because there you need to go a bit more and to assess patients. Okay, so post-operative. Post-operative after any procedure, I mean, excluding maybe I would say vertebroplasty, all the other or neurotomies, I would go in with something known as a neutral spine. So the goals of post-operative is, number one, is to actually educate them, teach them proper mechanics, teach them, modify their ADLs according to what surgery, trying to give them an hope to return to their appropriate activities. If somebody was not skiing before surgery and he has a goal, it's not going to happen soon. But if that is his goal, then you need to guide him through probably the next few weeks to reach there. So you need to have a realistic goal, and you need to sit together with your patient and have it. So something which is interesting is that lifting the muscles away from the bone impairs blood supply. This is surgery, and disruption. What it causes a disruption of the nerve and blood supply, can cause the muscles to fatigue easily, especially after a long work day or heavy. So just to keep in mind, so when somebody is doing that on a surgery of just moving, that simple movement of muscles or retraction or separating the muscles to give them the window to do the surgery itself creates a lot of disruption onto the blood supply and the nerve, which causes muscles to fatigue. And this is a known thing known as a surgical fatigue onto any muscle of the body. So just bear that in mind. So your muscle contract index might be a bit different. Patient rehabilitation programs. So ideally, this is just a thing for us. We need to make sure that the patients have clear understanding what it is. As a therapist, you should understand that each and every patient have different anatomical abnormalities, and surgical procedure is dealt with differently, each of them. Patients have different levels of strength, flexibility, and conditioning after surgery. Patients possess different levels of kinesthetic and proprioceptive coordination. So their motor learning is different. So you cannot randomize or generalize and give you a program to everybody and say, this is what we use internationally. No, the person who has his anatomy is different. Every single person is different. So we have to work along onto their needs. Okay, so what we focus on most commonly, just to understand, I mean, these are the core muscles. I'm just, like I said, we do thoracolumbar. Cervical itself will be a daunting task, so I just sort of taking only in the lumbar spine now. The back, you have the erector spinae. Most common thing is the multifidus right here, which is the key muscle. In the front, you have your external obliques, your transverse abdominis, and rectus abdominis, so commonly known as the TRA. And more deeper, you have the psoas major, the iliacus, very much into the whole firing of what we call as the core spine muscle. And this chart here gives you an idea of what exactly happens. This is your spine, this is your anterior fascia. You will see your obliques relaxed. what happens is the transverse rectus contracts. That's where you get this core stability along with the help of multifeeders and the pelvic floor muscles. Just to give you an idea, post-operative, before you start anything, you need to clear off red flags. Red flags as in if the patient is saying increasing lower limb pain or extremities, any symptoms. Pre-operative symptoms was numbness up to the knee. Post-operative numbness has gone down to the toes. It's a red flag. So you need to alert them. And if your neurological deficits, muscle pain, muscle strength is increasing, you see there's foot drop or toe drop, go ahead. And pain is increasing on basis of activity or non-activity. So you need to understand. So these three things have to be documented very clearly after the surgery. So just to brush through, so I'll go through fast. But now we have three phases. The first is a protective phase. Second is your stabilization phase or the recovery phase. And the last would be a resistive training phase. So we divide the whole lot of spine surgeries into these three phases. The first phase is the first 3 weeks, hospital and / home. Generally give them very basic exercises, to switch on the core. Your instructions, we try to video the patient, we give videos and we send them across, and they have a portal, so it's easier to interact. We Zoom them, and the last 2-3 years, that's what we're doing more commonly. So it's easier for them to know that they're still connected. So basic home exercises, and just try to get them to be more mobile in the first 3 weeks rather than pushing them to do too much of exercises, especially the senior citizens. They don't remember, and they don't want to do, and if they're not used to exercises, it's really going to be hard. And their pain is something which you need to know. So we advise pain, so hot packs at home if needed. Any sort of pain management, like I said, TENS, go ahead. So this is most common thing which we do. And again, our criteria here is to protect and the surgical site and to promote the healing. And this is the key right there. And if we think that patient is not going to do well at home, we try to get them as an outpatient every 3 to 4 days at least. So face off that first stage. Second stage is where, as mostly seen at outpatients, and just mark them in red lights. The red highlighted one is probably the most important one. Teach them the neutral spine concept. So if you're doing core stability, let's say you want to keep them in supine, and try to switch on their core muscles in supine rather than asking them to do something very dynamic in all fours or planks or on the ball. Right now may not be the best time to push too much of movement on the spine. Address if they are going back to work, or they are having some recreational activities which they do, going to their regular friends to play a deck of cards. Or so if they want to do something like that, you need to address it. You can tell them how much time they are allowed to sit, how much they are allowed to move. Come back to sitting. Just quickly make a note. Other than microdiscectomy, if any sort of fusion is done, they are allowed to sit. And they can't sit. Actually, sitting is helping the fusion to get better. So it's much better to do that rather than to, after microdiscectomy, you need to be careful. You don't want to sit for a long time. So except for that one surgery, the others are fine. The last one, maintain the nerve mobility, extremely important. Like I said, elderly or the senior citizens, they may not do the exercises properly, so you have to go hands-on and get on with the nerve flossing. You have to make sure, because their nerves, the nerves will get a bit more tighter than younger, healthier nerves. Other than that, start thinking about spinal control, stabilization and trunk control. Cardiovascular conditioning can be added in. They can sit, they can do a biking, strength training, and balance activities if you want to add in standing preferably. Some of the things which we have, number one is this is the machine which I was just talking to you about, the exercises. You walk in there and it's filled with water, and the treadmill is down there, so you can actually walk in. So it's really helpful. Something which I love using, again, this is called a biofeedback. This is a stabilizer. It's from Chattanooga, the brand. I use that a lot. So that gives, when you check for your core stability and you use the stabilizer, you can have a clear understanding if your muscles are switching on or not. It's an amazing machine. You can Google it up and you can read about it. it's a bit too much on this talk right now to go ahead. Otherwise, yeah, the flexibilities, do a little bit of training, teach ergonomics. Like I said earlier, most of our senior citizens now are still working, and they prefer to do so. So they need a clear understanding on how to sit, how to go ahead, especially with their work. The last stage in spine surgery, probably the last few weeks, we'd say from the 6th to 12th. For senior citizens, I would push that 12 weeks to 16 to 18 weeks. We really follow them all the way up to the 4th to 5th month. Ensure, number one, patient is independent in self-care. This is number one priority. All the ADLs needs to be ticked on. They need to be free. They need to be absolutely fine. They should be able to return back to all their functional level as before surgery. So this is your criteria. And if you haven't met it, you're not discharging the patient. And you need to think about discussing with them on advanced lifting or postural training. So what is needed, you need to work on, especially when you go senior citizens. Again, I'm coming back to senior citizens because anti-gravity muscles play a huge role. And this is where you probably want to start working a lot on the anti-gravity muscles to work on, especially that thoracic area muscles, which I was talking to you about earlier. So winding up, key points. I think it's a bit more on surgeries for early morning, but key points on the rehabilitation. What we do is one-to-one. You have to have a primary person to deal with. The stabilization program, the flexibility and strength program. Again, when you remember strength, proximal strength comes before distal strength. So if you want to strengthen something, strength first the inner or the proximal areas before you start working on distal muscles. So you work on your core, your lumbar spine, your trunk before you start working on too much on the leg muscles, which is what is advised. Just a quick thing, if those who are interested to understand the iliacus muscle, which is more into recently into a lot of research, iliacus, and how much it is involved in core muscle development, and how much neuromobilization is helpful in spine surgeries. It's still on a debatable part, but still, yeah, that's still going on, and we're still working with the same. Right, and this is my references. Thank you so much. And this is where I work. We just had last week a back-to-back program. So it was a World Spine Day, which we celebrated, in which we had an open day for the same thing. Again, like I said, elderly, the management is, or senior citizens, it's damage control basically. So if how much damages can be prevented, that much better. So you need to assess which system is on a damage. All right, so I'll wind up with that, and thank you so much.
Thank you very much, sir. A very wonderful session.
Thank you.
You have mentioned A to Z of things in a brief manner and a precise way, which is necessary for the physios, that you explained well. We are finding some physios after getting 1 or 2 courses, immediately they jump to the practice and they will just manipulate, break the bones, break the system itself. That creates a lot of problem. You said the chiropractic, they are doing the add-on practices, they are doing. That creates a lot of trouble to other professionals, making us to be little precautious. The dangerous people. That is the problem over there in the practice that you mentioned properly. Okay. Then you mentioned about the differential diagnosis. That is very, very important in physiotherapy practice. Most of the times we are unaware about a few of the conditions which are related to that one. And if you are not ruling out that problems, it creates a lot of trouble in the treatment program and all. Then one more thing is there. You said in India, TB is much more common. In other countries and all, not much. Okay, so most of TB the times we are in trouble with metastasis. Okay. Most of the times we just next the metastatic ones, and another one about the osteoporosis. These two, it's a lot of trouble to the physios. That may be the pointed out by the physicians or else the surgeons about the physios who are not taking care of the patients. So these areas, if you are so careful, then we can lead a good practice over there. And one more thing I noted down, that team approach. That is very much essential. Just like I am treating a patient, so I should not give way to somebody else. No, it's like a team approach. All collaborative work is needed. Then only we can have a good result out of it, and others will appreciate our work. They will know our work. The thing is, we are not showing our work to others because we don't want others to interfere in our work. That is the problem. So you mentioned about the teamwork. It is well said. Then the assessment, subjective, objective, and as well as the psychological one, which is very, very important, because I'm also very much interested in that aspect. Psychosocial and the vocational training also. These people, ADL activities, what is able, then what is unable, then how we can do the prehab and post-rehab sessions and all. Well said, sir. In surgical things, you are very versed, very well expert after surgical procedures.
Oh, that's enough. Don't flatter me more.
No, it was very nice to hear from you. Without any hesitation, it is coming like a flowing, tuck, 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 tuck. No, it's very difficult for others. Through experience only it will come. I could understand your expertise in this field. Okay.
Sure.
I think in chat, questions are not there. Organizing team, is there any questions in YouTube or something?
Yes, sir, please. Just hold on. I request our participants to post your queries in YouTube, and I request Dr. Rupesh and Ms. Duna to copy paste the questions here. And dignitaries who are available in Zoom, if you have any queries, and kindly unmute and you can ask.
I have posted the queries in Zoom chat box from the YouTube.
Yes, sir.
Let's Joseph, kindly, can you check the Zoom chat box, sir?
Yeah. One question by Dr. Richa Shah. When can aquatherapy be started post minimally invasive spine surgery?
Okay, I read the questions. Yeah, I got the questions. Richard, so any surgery for that matter, before you go into aqua or any sort of aquatherapy, the first thing you need to know is the wound closed? Because the only thing that is going to prevent you from going in and starting aquatherapy is chances of having a wound infection, nothing else. So you have to be absolute. And when it comes to spine, we need to be extra cautious, because that is one area of your body which you don't want to have an infection. Infection goes in, it goes straight into the spine, and if it goes into the spine, it's a big disaster. So unlike other parts of the body, if you have a knee joint, knee replacement, and if it gets infected, it's easier to irrigate it, to take care of it. So yeah, my thought would be a complete closure, or what we use here is what is known as wound sealers. So these are stick-on sealers. So you put that over the wound and it completely seals, and you are allowed to take showers, or you are allowed to. But still, even though it seals, we don't ask them to go into a pool. So the pool, ideally, we would say around 4 to 6 weeks post-surgery. And it has to be cleared by the GP that the wound is completely closed, and they need to assess the wound very well.
Okay, nicely said, sir. Sir, next question is by Dr. Vijay Nambi. What are the challenges in spinal rehabilitation for post-surgical elderly patients?
Okay, yeah, I'm reading the question. So what are the challenges in spinal rehabilitation for post-surgical elderly? Okay, so post-surgical, see, the first challenge would be the challenge you set before surgery. This is why your preoperative assessment is so much important. Like I mentioned, the prehab phase. When it comes to senior people, we try to push the elderly phase to 1 month, so they get used to what they are going to go for as a surgery, and after surgery would be easier. Now, if you haven't done that, and your institution or your hospital does not give you a prehab phase, then post-operative, the biggest challenge is usually to get them to do your exercises. This is because especially some of the senior citizens are pampered by their family, and then don't move, don't do this, don't do that. Oh, you will break the bone. All these things, the patient's family starts to go ahead and tell, and that is a challenge, the family, not the patient. So for me, that is the biggest challenge, to actually get the family on the board and tell them that this is fine and your father or mother will get better. So this is the biggest thing. I hope that I answered you, Vijay. I'll just go through. I'll read the question. It's not a problem. And the next one is from Raj Kumar. What are the main points needed to focus senior citizen rehabilitation from normal citizen? Okay. I guess you mean to say is with regards to the age. Again, rehab program for whatever reason, spine or non-spine. What I would say is the biggest things you need to write, like I said, is first, you need to know what is their expectation. And after the surgery, will you actually meet up their expectation? So this is the first thing, especially when it comes to elderly people. They want to be independent. Most of them, they want. So if it is, then tell them, because don't promise them if they have very bad spine and they have, like you were mentioning about paraplegics, or you have a severe quad equina and they have lost muscles, and if it's going to be hard, you have to tell them the truth from day one that it's going to be hard. It's a long road. So yeah, it's not easy, because when they are elderly, they're not going to really be very motivated to be actively participating. It takes you a lot of time and effort. You really have to spend a lot of effort trying to convince them, trying to motivate them. So you play a role of a psychotherapist more than a physiotherapist at times. So yeah, that is the biggest challenge, Raj Kumar. Richa, you were asking, yes, it is. Stair climbing is absolutely permitted post spine surgery. We actually do it on day 2 or day 3. Depending on how the neuromotor condition is. If the pain is too much, we would avoid it for a few more days, but definitely before discharge, it is a criteria to be taken. And what precautions? Precautions is generally if they had weakness. Let's say if they had weakness on one side, leg, so I would say that is a bad side and the other would be the good. So we generally stick to the general rule that good goes up to heaven and bad comes down to hell. So you go up the stairs only with the good leg, and when you come down only with the bad legs, just to avoid loading onto the bad leg, especially the nerve. You don't want to stretch it, you don't want to load it too much and create a reflexive spasm or pain, which might just freeze the patient and take us a few steps back. Richard, hope that answers you. Next one is from Vijay. Is that respiratory muscle training is needed for post? Yes, like I mentioned, PNF breathing pattern. Respiratory is definitely a yes. Luckily, I didn't mention too much because we have respiratory therapists and they deal with it, unlike the system. So because we have more of a different system, so we don't go too much with the respiratory muscle training. In our department, we have respiratory therapists, but definitely you need to teach them, especially doing active breathing cycles, deep inspiration, expirations. Definitely, you have to, after any surgery for that matter. Muskan, what will be the protocol for spinal carcinoma? It depends on the surgery rather than the condition, Muskan. It doesn't matter what it is, myeloma, carcinoma, whatever it is. It's what the surgery which has been done. So as per the surgery, we make a protocol. And I think I just mentioned to you a huge lot of most common spine surgeries which are done. Now, oncology and cancer training, cancer is a completely different thing because they go in not only with the surgery for surgical removal of maybe the malignant tissue or the bone tissue, plus they might be having radiotherapy or chemotherapy or whatever. So yeah, the rehabilitation would be a little bit different, Ms. Khan. That would be, I don't know, it's a little bit beyond our talk today to go ahead and oncology, because I'm not a specialist. We have others who are better than me. They will probably talk about that. But about the surgery, if it is a simple vertebroplasty, which has been done after spinal carcinoma, or if it is a removal and with the fixation, you follow the same as a fusion and fixation protocol, like I mentioned earlier. Shiva, one patient came after, this is it laminectomy, discectomy surgery? Craniectomy, I'm not sure about the surgery done. You have to stop knee extension. I didn't quite get you. Okay, craniectomy. Knee extension, craniectomy. I didn't get you, Shiva, physio-care. If you could just rephrase your question. And Vijay, what physiotherapist needs to consider on assessment for prehab? Okay. Like I mentioned, your assessment. You need to consider is your key assessments, your subjective and objective. And you need, in objective, you need to, Vijay, make a clear picture of your markers. When I say markers, these are things which you can measure. So when you write manual muscle testing, say dorsiflexors 3/5, dorsiflexion on the foot comes from L4, L5. Nerve root, L5S1, extensor hallucis, 3/5. This is your objective marker. Nobody can take it away before surgery. After surgery, if it's the same, very good. If it is improving, much better. But if it is getting worse, then we have a problem. So you need to alert the surgeons and say, look, so it means the nerve is getting some sort of a contusion. So they may need to reoperate on the same patient. So those are the markers, and this is what we do. If it is more specific, let's say lumbar stenosis, and I do a walk distance assessment. So the patient is able to walk, let's say 500 meters without any back pain or heaviness of the legs. And after 500 meters, he needs to sit or bend. So that would be my target, 500 meters. And post-operative, we see if the patient is improving from 500 meters beyond that, which shows clearly the stenosis decompression surgery or laminectomy has helped him. Hope that answers you, Vijay. Lena, what is the reason of weakness seen in bilateral, unilateral low limbs seen post-spine surgery? Most patients have weakness before. Oh, yeah, this is very good, Leah. This is a challenge for all physios who are dealing with spine surgeries. Especially, I mean, most common thing is we've seen is cervical 5, C5, and L5. So L5, the myotome is most common. You will see after surgery, most of them going into. It is all because of the surgical approach and how much traction and distraction the surgeons are doing during the surgery. So they want to clean up the disc, they want to pull out something. If they do a bit too much or they touch the exit nerve root, they end up in having definitely weakness. And this is a challenge for all of us. Oh, sorry, you can't hear me?
Yeah, it's okay. It's
clear, sir. It's clear. Maybe the person have to check the network.
Okay, so Lena, I hope I am answering you, but definitely, I mean, I know most of the surgeons would not like it, but whenever I do presentations in a surgical or within the medical faculty, they don't like me saying this, but yeah, it is a truth. It's a surgical error. It is not a physiotherapy error. It is a surgical error, and they have to deal with it. But unfortunately, we are the ones who have to take care of it and get them back. Okay, I think that's the end of all questions. I think I've taken more time than what was given.
It's okay, sir. Knowledge sharing is welcome.
Sure.
Over to Gladson, sir.
Sir, you have cleared all the doubts of the students with the questions which were asked. And I have to thank you a lot because they got a very good idea about the spine and the spinal surgery, what physiotherapists should do, not to do. That is very, very important. What precautions they have to do, what dangers will be there. Everything were explained in a very well manner. Thank you very much, sir.
No problem.
I thank the organizers, Dr. Magesh Babu, my colleague, my good friend. I thank Dr. Chandramohan and my student, Dr. Arunima. I thank Dr. Aroma and all the entire team. thank you very much for the opportunity given. It's a very, very good opportunity for us to meet each and everybody. All experts, all legends are there in the GERICON. I thank you very much, sir, Dr. Binil Pillai.
Absolutely. Thank you again for flattering, and yeah, thank you guys, and wish you all a wonderful day and excellent day of learning for the day today and tomorrow, and take care. Bless you all.
Thank you, Dr.
Thank you,
Binil Pillai, sir. And
Yep.
thank you, Professor Dr. L. Gladson, sir, for setting time aside from your heavy schedules to share some valuable information with us. It was indeed a knowledgeable session, sir.
Thank you.
Sure.
Well, with pleasure, I invite our guest of honor, Professor Parthasarathi, Principal at Meenakshi Academy of Higher Education and Research, Chennai, India. With immense pleasure, we welcome you, sir, for a few words. Professor Parthasarathi, sir, over to you.
Duna madam, can you check?
Yeah, he is there, sir. I am sending unmute request, but not in getting
Also,
any.
I request someone has entered the name as iPhone. Kindly rename with your real name, please. I repeat it again. Someone has put as iPhone. And also, I request dignitaries to keep the mic mute unless until if you are talking to a resource person. Over to Team GERICON.
Yes, Parthasarathi, sir. Kindly unmute, sir. Makesh, sir, can you kindly communicate? He is there in Zoom. Hello? Hello?
Madam, I don't see him.
He is in the name FPT Maher, sir.
Okay, okay.
Sir, Chandramohan sir.
Sir.
FPT mother is Parthasarathi, sir.
Okay, okay, sir.
Okay, sir, can you kindly communicate with him?
Yeah, okay.
And after Parthasarath's speech, we will be taking 5 minutes break for Team GERICON. I know participants will have their own break time. Just we will be taking only few minutes for us, and we will be continuing with our third topic, and we are having our next speaker online also. And kind request for all our participants, put your attendance in YouTube live chat. Subscribe to the channel, and then you can write. In case if you cannot write, take screenshot of the session for attendance purpose. When we ask, you can provide it to us. I repeat, for the registered participants, you just write your registration number and name only. Don't put your phone number or email ID there. Write your registration number and name for certification issuance. This is pre-break attendance.
Yes, Makesh, sir, you were asking something?
Yes, madam. Yeah. Sir is a little busy. Parthasarathi, sir. He will be joining quite later. So we will go on as per our schedule.
Yes, sir. So we will have 5 minutes break. I think I request MC to announce the break,
Okay,
and
okay.
we will be back.
Okay. Now we can go for a short break. I would like to request all of you have a short break and we will resume at 11:20. Okay.
Yes, madam. Thank you, madam. Dear participants, we are taking rest. Kindly stay with us. I know you all will having your own break, but we cannot move. So we are taking rest for 5 minutes and we will be back. Those who are in Zoom, kindly stay with us. And here is an announcement that we are having another physical conference by Society of Indian Physiotherapists, which will be happening on January. The details are here. For more details, you can visit their website. Duna madam, you are there?
Chandramohan, can I share my screen and see?
Yes, madam. Yes, madam. That's
Just
why.
for, just for a while, I'll just share it and see.
Yes, madam. Mahesh sir, kindly check chairperson availability.
Is it visible?
Yes, sir. I am here. I am here. I am here, sir.
Is it visible?
Madam, actually, Duna madam has shared from her screen, madam. She has to close
Okay.
that one. Yes,
Okay,
please wait.
Shall we start, sir? Chandramohan, sir?
Madam, please wait, madam.
Okay.
Yes. Ramya madam has here. Yes.
Good morning, sir.
Good morning, madam. Madam, remember to keep the mobile in a horizontal way so that you will be seen full screen. Yes, please try. I just need time. Annie madam, please go for full screen.
Is it visible?
Yes, madam. It is visible.
Right now?
Yes,
Hi,
madam.
Annie ma'am.
Yes,
Hello,
can
Ramya ma'am.
See whether it's moving?
Yes, madam. Moving,
Okay.
madam.
Yes, thank you.
Sir, is it okay?
Shall I unshare?
Yes, madam. Yes, madam. Yes, Ramya madam. Yes, Annie madam. And Team GERICON, if all we here, we can start the program now. And Rupesh, you can announce that post-break session topic 3 has started in the group, especially in GERICON registered participant group. Makesh sir, Stalin sir, Arunima madam, Aroma madam, are you all there? Can we start?
Yes, sir. We can start, sir.
And Duna madam has to tell
Yes,
who has. Yes. Yes, Duna madam. Carry on. Who is the concerned person to
Yes.
start, please?
Mrs. Aroma madam, are you there?
Yes, ma'am.
Yeah. Would you please invite our respected chairperson, Ramya ma'am?
Okay, okay. Thank you, ma'am. Okay, I will leave it. Okay. It's my privilege. It's my privilege to introduce our next chairperson to the session. I would like to welcome Professor Ramya madam. Madam was currently working as a professor and head of the Department of Physiotherapy, Little Flower Institute of Medical Sciences and Research, Kerala, India. She specialized in neurology and pursued MSc Yoga in 2019 and possesses 15 years of academic experience. We are so privileged to have you here, madam, to grace this event and host the session with our third resource person. Over to you, madam.
Good morning, all of you, and thank you for the introduction. I'm very much pleased and honored to chair this session. I would like to introduce the speaker, Dr. Annie Thomas, who is a neuroscience physiotherapist working as Director of Physiocare and Research Coordinator, School of Health Sciences, Garden City University, Bangalore, India. Dr. Annie Thomas has a wide experience of academics as well as in clinic over 20 years. She completed her PhD in physiotherapy in 2017, and she explored the comparative analysis of motor control stability exercises program and strengthening program in the treatment of chronic back pain among male weightlifters. She has pursued her bachelor's from RGUHS with gold medal and Master of Physiotherapy from Calicut University with first rank. Adding to her credits, she has presented 30 papers in national and international conferences in the field of physiotherapy, and she is being the resource person nationally and internationally in the field of physiotherapy and ergonomics. She has been certified by the International Association of the Study of Pain. She is certified by SGRI Bangalore in research ethics Grant Management of Health and Social Science Research. She is a part of Research Ethics Committee in Geriatric University. She has grant-funded projects in national and international levels. She worked as a NAC coordinator in JSS and also in St. John's Medical College. And coming to his career, she worked as in JSS CPT, Mysore for 15 years and later in St. John's Medical College as professor and head of the department. She is the guide and evaluator for PG and PhD students in Guardian City University and various other universities in India. She has received various awards and accolades, and she has been awarded the prestigious GCU Puraskar in 2021. She received assisted world record for most number of topics in free live webinar, international webinars as a resource person. She is an editorial member in IAP journals and reviewer of journals in Elsevier and 5 other journals. She has 20 publications in her credit in reputed journals, and she is a fellow member of Scholar Academic Scientific Society. She will be sharing with us her views and ideas on adaptability in community among neurogeriatric condition, which has a major significance in geriatric rehabilitation and is a socially relevant topic too. And with that, I would like to kindly and cordially invite Dr. Annie to this presentation. Over to you, ma'am.
Thank you, Dr. Ramya. It was a wonderful welcoming from your side. I think I'm audible, Chandra Mohan?
Yes, madam.
Yes.
Very much.
Yes. Thanks a lot for this opportunity, Dr. Makesh Babu and Dr. Chandra Mohan, Doona and Rupesh. The team which I would say that the more excellence in especially in conducting the conferences and workshops and reaching out for the children and the staff, and also those who are in the clinical field for sharing their knowledge and also exposing their areas. I think Chandra Mohan and team has reached almost every countries, and your participants list also, if you see, you can see it is encroached to different countries. Thanks a lot and for giving this opportunity. With this, I'm going to start my topic. It's related with neurogeriatric conditions. When I say it's a big topic. So what I am trying to say here is basically the adaptability in community. So when I say adaptability in community, many things comes to our mind, especially in geriatric populations. When I say they have different kind of issues, as Binal sir said, musculoskeletal issues, spinal conditions, and in general geriatric, the comprehensive way of viewing it, if we say they have chest issues, they may have neurological issues, it's multiple things. So when I go for a neurogeriatric topic as such, the geriatric populations geriatric population may not be in the concise form of a neuro conditions. Maybe they have some other conditions which is associated. So when we approach a patient or when we approach a geriatric population, we have to take that patient as a holistic way. That means from head to toe. It's not like generally we should go in the direction of neuro or cardiac. Our specialization is not very much maybe the inclusive one in geriatric conditions. That is the main thing we have to keep it in mind. So whoever is treating any geriatric conditions, we should have a knowledge about the geriatric health. In the geriatric health, in the sense, it may be in the form of musculoskeletal, it can be in the form of cardiac, it can be in the form of neurological conditions, whatever it is, we should have a thorough knowledge about aging in the geriatric. So, as of now, if you think of, we say geriatric population is about 63, now the current is 65 years and above. But if the declining or the degeneration starts from the age of 30, that nobody is trying to understand. So our body starts, it goes to the peak of growth, then it starts its declining process from the age of 30. So the maintaining the fitness level starts from the age of 30. It's not like we have to start at the age of 65 or we have to deal with the condition at the age of 65 above or 60 and above. So it's like the fitness levels or the conditions which is coming to our body, maybe much before 30 also sometimes, but declining process starts from the 30. So general fitness for as a person, we have to take care from that age period itself. That most of the time we all forget it. So when we say about everybody is behind now fitness and other things, but what is a fitness? Is it going for a gym is the fitness? Is it going for a keto diet is that fitness? Is it going for like walking is a fitness? It's not. Like it's a like every aspect of our life is a fitness. It's like when you say you may have physical health, that is what we always concentrate on our balanced diet and exercise programs. Even we try to do this on our patients also. But when I say about the fitness, it is the aspect of our mental health plus cognitive. So there comes like a specific time when we say we call it as a neuro conditions, or when the cognitive decline happens, we say it's a neuro conditions like that. But when you say about the fitness, this all concept is there in our mind. So when we are going to, why I said this means when we are going to approach a geriatric populations, so we have to see to that these all components are included, and we have to try to prevent it first. If it is not preventable, if it has already reached and the health is affected, then we have to keep this concept in the mind when you try to rehabilitate any geriatric conditions. So if you see if you see what is neurological disorder, so many points may come into our mind about neurological disorders. As we know, the first thing comes in our mind is about stroke, then head injury comes, so traumatic brain injury we can say spinal cord injuries, we say Parkinson's disease. But when we say neurological disorders, most of the time in elderly population, if you try to understand, we can see the first and foremost is it Parkinson's or Alzheimer's or sometimes dementia. But there are other prevailing conditions which is not very popular or which we may ignore. That is the neuropathic conditions or general weakness of the patients due to degenerative in the brain or degeneration in the musculoskeletal system. So any neurological conditions or disorders is due to the damage of some part of the brain or the nervous system. So brain or nervous system, when I say it is the brain and spinal cord, including your nervous system, peripheral nervous system, your cranial nervous system, your autonomous nervous system, all components are included in the neurological disorders. So as we age, you know, all the organs of our body get damaged slowly. So if you see, as we age, what happens, all their functioning will start slowing down. So it's not only the brain, it's the whole body, it starts slowing down its process. And it will have some biological changes and it will have chemical changes. This both are there, which when the age started declining or the functioning also start declining. So the same thing is applied to the brain and nervous systems. So that's why we say hence elders, those above the age of 50 are more vulnerable to neurological disorders. But it doesn't mean that below the age is not affected. Yes, but now we are concentrating on elderly populations. So I'm saying about it. So when I say the age decline happens, as you see in the musculoskeletal system or the connective tissues changes, the same thing happens in the brain and your nervous system. And it is more likely to happen above the age of 50. These disorders what happens, this will terribly affect the elderly population, and they have the ability to live independently. That is going to decline. So they'll be more inclined towards dependency on the caregivers, or maybe they like to be in a withdrawal position where they'll be in the rooms or in the house where they don't want to move out. So that is what happens. As it progresses, what happens, the condition becomes worse. Actually, if they are trying to come out of it, maybe the condition would not have been worse. In some conditions, we can understand it is a progressive conditions, it's a rapid progressive conditions. In case of multiple sclerosis and all, it may go for worsen the conditions, but a minimally affected conditions, which the person can come out of it, will get affected because of their life independency, which is going to get affected. So if the proper treatment is not used, then definitely the declining process is going to be faster and the patient will be more independent on others. So the term adaptability comes in that. So as you all know, in our brain, we have a prefrontal cortex. which is we have blessed to have it. So it's like saying that if you have the headphone, if you keep the headphone and we can see the prefrontal cortex, that's the way. So there is multiple functions of our survivals, daily routine life or daily activities is carried out in the prefrontal cortex. So its main function, what is its main functions means it helps us to adapt our environment. Okay, so that's why. So if, for example, if I say one example to you, if you are in your house, okay, if you're going to your friend's house, or if you're going to your your relative's house, or if you're going to a hotel room, so the placement of the things, or the placement or the space in your room, in your house is going to be entirely different from wherever you're going to stay at that moment of time. But the brain gets adapted. It's not going to say that that was the size of my room, the same thing I wanted, otherwise I cannot adjust. See what happens, the brain itself is getting adjusted. The brain is getting adjusted so that our body is also going to get adjusted. So the human beings have a wonderful things that we have the adaptability to the environment. So that's why it's like that any harshest conditions, like from Arctic to Amazon, so that any conditions when the person is put up, maybe the initial difficulties comes later on, then the people may get adapted to it. So for example, if those are going for trekking or something, you can know high altitude, when you go, what are the things can happen to your body, but doesn't mean that you cannot come back to your normal area where you're living and you cannot leave. Yes, you can. At that point of time, the environment was difficult for you in the initial period, but later on it get adjusted. So that is a wonderful process of our brain. So that's a gift from God, which is given to us. So any kinds of tools, language, or cultural advancement, all these things are well developed in our prefrontal cortex, and this will help to adapt our body to the brain, to the brain, and then to the body. This is the plastic nature. We say it is like a plasticity of our brain. We have the strength to adaptability. So suppose, for example, when we go for conditional exercises or we go for exercise training programs, what happens here means those are going to gym, or those are going to do exercises, or those are going for regular walking will be knowing about it. So if you go for walking regularly, and if you have not gone for 15 days, you can see the changes on the 16th day when you start again. Okay, so what is that? Because that regular things has changed for 1 month or 15 days, which has that adaptability was somewhere lost it, and again you are starting. So that is the point where comes our exercise programs or corrective exercises things, which makes the persons to strengthen their ability to adapt to the situation. So this is very much required for the geriatric populations. So especially in chronic illness or geriatric populations, these accommodations are very much, or this adaptability is very much required. When I say accommodations, we have many things in our mind. When we say accommodations, like we are trying to accommodate with whatever exercise programs or whatever things which is happening in your body, which you wanted to correct it. So that is why our exercise program is important. So any population, even geriatric population, the exercise program is required. It doesn't mean that the person has to go to the gym and pay 7,000 monthly and do a gym regularly. That is not required. A regular program, at least 1 hour. What is the regular exercise programs, which starts with the stretching or warm-up exercises? Go with the flexibility programs, go with strengthening, agility training, which will help the person to maintain their lifestyle. So that is very much required. Sometimes some people feel walking is better. Okay, let it be. But how much, what was the thing, and how much amount of walking, what is the pattern of walking is very much important, even in the walking style or walking training, which you're going to take up, or any kind of exercise programs. So if in geriatric population, the conditions comes, usually what happens in physios, what we have observed is the patients will be taken care in the hospital, right? The patient will be discharged, some amount of exercises would have been taught, and the person would have been gone home. After that, there is no follow-up. Sometimes the person will be taken care of at the home with the home physio, whatever it is. But what is the adaptability? What is the accommodation you're going to teach? Is that regular exercise of passive movements or strengthening programs to stand, making the person the walking in the room? Is that sufficient for a person to have their independent activities of daily life? No, the person has to be taught how to come back to the community life. That most of the time we ignore. If the person is given a strengthening, or if the geriatric population of 65 years old man had a stroke on right upper limb, okay, let it be. If the recovery is taking time, why can't we teach them to use the left hand and to do his daily activities? Why the bystander or the caregiver has to feed the person, give the spoon, make him to use the eating pattern? So most of the times what physio thinks, that is occupational therapy job. Okay, that is one thing in our situation we always find it. A physio is over a occupational therapist, actually speaking. We can deal with many conditions. I'm not telling that superb or something, but we are learning the functional activities plus physical activities. Most of the times we ignore the functional aspect of the persons. We generally think of physical abilities, strengthening, flexibility, range of motion exercise. These are the common things which we give. Even we focus on gait training. The gait training is only in your clinics or in your hospital setup. We are not thinking what is the gait person the person is going to learn outside that clinic. Okay, so there comes our role. So as a physio, that's why I said we should teach this in a holistic way. That's one important thing we have to keep it in our mind. So the person who was really ill only will understand what is the need, or what is the person's independency level. Okay, what is, how much independent they are, how much dependent they are. That person only knows what are the problems they have. So as a physio, we are able to analyze that conditions, or what are the assessment. If our assessment focus on all the physical functions plus all the cognitive and mental functions, then we can have a proper exercise training programs which can adapted by the human brain. That is the peculiarity, as I said. So we should be adaptable and flexible almost all the times, because sometimes the person's conditions can be very sometimes it may worse, or sometimes the comorbidities may take up the patient to a toll. So situations comes, so we cannot expect always our treatment is going on the right way, the patient is going to be all right. Sometimes the toll may, or we may have to take a back step. But the thing is, why it happens means we are not generally thinking of what is the patient's the common concept, or the all the aspects, whether we have taken care or not. So that's what an accommodation we must be willing to say, I can do that day, maybe tomorrow. That is what means the person is able to understand their conditions, and they know that today I cannot do, tomorrow it does. That is that phrase meant. So when you think of a particular patient, especially neuro patients, when you think, it doesn't mean that you have to teach the person a particular thing. The person is not able to, suppose for example, the patient is able to sit. Okay, a 65 or 70-year-old man can sit even though the person has got some amount of Parkinson's, or with stroke or traumatic brain injury, whatever it is, a person have a sitting balance. If that common sitting, if the person has at least achieved that sitting balance, that meant to say that he can do a lot of activities in that sitting position. Sometimes he wanted to reach out from that sitting positions. The dynamic balance may not have gained for the patients, but see to that what is the supporting. Suppose if they have a pillow near to that, or they have something which can support their hand on the other side, and they can reach out. Okay, it should not be make them to be more dependent, saying that you cannot reach out, I'll take and give. So that's a simple example. So that itself is an accommodation for the patients. So most of the times we don't realize that it's not like sitting, standing and walking and dynamic balance, patient walking independently or patient walking with walker or crutches is the main thing for us. It's like a simple task the patient can do it or not. If the person is having a stroke, as I said, a right side stroke, the patient is able to do a dressing. Okay, suppose right side stroke, the right hand is not recovered, but the lower limb would have been recovered for the patients. Why can't the patient having a standing balance with a walker, or he can use a tripod or quadripod and he can walk around? that patient can definitely lean on a wall or bed and can put the dress or the pants with the other hand. This we normally won't encourage, or we will not teach the caregivers to do that thing. Okay, if you ask the person, they'll say everything is done by the other person, which is the point where we say the accommodation has not come. So the brain has reached its adaptability, but the person is not trained for the accommodations. So many geriatric populations, if you see, sometimes like previously Brinal sir has said about your spinal injuries and surgeries and all. Even we have seen some cases, the person might have gone for a simple laminectomy or discectomy, and what happens, the patient will be on bedridden. The physio must be coming and doing the exercises. Rest of the time, the patient will be on the bedridden. If you see, if they have a good house and everything, they might have kept the table, chair, everything for the person's room itself. So the patient will be just get up and walk towards that table and have the food and come back and sit. They will have a toilet and everything near to the room. So the patient will go there and come back. But what about the other accommodations? Why can't they go to the other rooms? Is it the same tile or this is the same room pattern? The space is, everything is good, but why they are not moving? Because they may have the risk, they may have the fear of fall. Fear of fall is one of the important thing, which may be the one which is reducing the accommodations. So when we deal with neurogeriatric conditions, these things we have to keep it in mind. The one thing is the conditions which is not allowing them to do the independent activities. The other part is the risk or the fear of fall in the patient's mind. These two things are the important components in geriatric population, especially with neuro conditions. Okay, yes, other conditions are like cognitive, emotional health, everything is that I'm going to come in. So as we know, why I said it's possible, the brain has a remodeling structure. Okay, the brain remodeling is always allow to compensate our existing weakness. So sometimes in stroke patients, most of the times you must have seen the upper limb recovery is very limited when you compare the lower limb, especially, and more form of stroke is MCA, and patients would have been affected with upper limb. So it doesn't mean that patient cannot do their daily activities. They can compensate with the other limb. They can walk around. They can do their daily activities. But this is by the brain remodeling method. The brain, the brain, two sides are equal and everything is formed. Only thing, how much neurons are developed from the childhood and improved and used. Okay, the other neurons may not have been used. That's the reason why the person is taking time to compensate. But even we should allow the recovery to happen. We should train that affected hand or leg. That is important. I'm not telling it's not important. It's important. But at the same time, to do the functional activities, we should allow the person to do a compensatory activity. I'm not telling about associated movements or anything. I said compensatory activity. So the brain is giving that functions. The brain is allowing to do that compensation. So we also should allow the persons to practice that particular kind of brain remodeling. Our exercise should be focused towards that side. So the neurons has the capacity to cross-link and know how to make up the brain tissues which is lost. So that's why I say the brain, the blind people also walk, the deaf people also walk. Even the deaf people have seen they're riding the bikes or vehicles. So how it is happens? The brain has its adaptability to compensate whatever disabilities the patient has achieved. The brain knows how to make the neural connections and to compensate over that. So brain regions care about solving certain types of tasks. So the brain itself knows how to solve the task, irrespective of whatever the sensory channels by which information arrives. So that's why one writer has said, the cartography of the brain constantly shifts to best represent the incoming data. So whatever the incoming data comes, the brain knows how to take up that signals and how to compensate or how to come out with the task. That is called brain remodeling. So when we think of in neuro conditions, the main key issues or the gaps which we have seen is most the age above 65 years have problems with daily living activities. So maybe in next 15 years, it is going to increase. So, and some studies are saying the dementia is very common in geriatric population. It is going to increase by 40%. So by around to 7.4% by 2025, the functional dependency level is going to increase. So this is showing that the persons will be more dependent on others, or they will be institutionalized either in the hospital or any sort of setup because of the nature of the condition. So these are the common things we have to keep it in mind. So when we say the plan, how will you do all these things? Okay, a clear care pathway is an important aspect in our neurogeriatric conditions. So when I say care pathway, any neuro conditions after 60 years of age, you should have a care pathway. What are the areas you are going to manage? The first and foremost point is crisis management. When I say crisis management, what is the problem the person is prevailing right now? What is the condition, or what is the residual things that happens for the patient? That management, we have to do it. Second point is rehabilitation. Rehabilitation in the sense it's not physiotherapy alone. Sometimes you require a multidisciplinary team. You may need a physician to check on his tablets or the things which is having an effect on our treatment and how much it is carried out, whether they're taking properly. Okay, we may need sometimes speech therapist. Okay, we need how to, sometimes the person's speech would have been lost or have difficulty in communications. We should learn that alternative communication from the speech therapist, and we should teach the patient. The alternative communication is very much important component in physiotherapy. That is always we should keep it in mind. When we say the communication issues is happen for the patient above 60 years, we should see to that what is the alternative communications, and that alternative communication has to be followed not only by physio, whoever is taking care of that patient should know what is alternative communications. If I say yes for nodding the head, the same yes should be carried out by the whole family members or the physician or whoever is taking care of that person. So that is what a communication is an important part. If the person understand that the communication issue happens, or they are not able to communicate with their family, but they're not able to communicate with others, that itself makes the patient to withdraw. Okay, they will go into themselves. So that is why rehabilitation is a multidisciplinary teams, and we have to be taken care. Disability management. Sometimes the disability would have happened. So how to take care? Whether the patient has some barriers that has to be taken care. The patient needs some assisted technology, give it. Okay, or if the person is not able to afford it, try to find out the resources which is available in our community to take care of it. So that is also our role. Most of the times what happens, either we prescribe splints or some frames and we just leave it. We don't see what is the economic background of the patient, whether they can afford it, or we can guide them. We may not be able to purchase and give, we are not able to do that. But we can always guide the persons to get that right place to get that things. So that is what disability management doesn't mean that it's only meant for exercise programs or adaptability at home or whatever it is. Resettlement. Resettlement in the sense, geriatric population is not meant to sleep in a one room or one bed. They have to come to the community. They should have a social interaction with their peer groups, or should have a social interaction with their community or cultural, wherever they are meant to. That is resettlement. Okay, so you should encourage the person to come out of it. Okay, even though they are not able, they are able to walk with a stick, let it be. But that encouragement and confidence should be given to the patient. Self-management. Okay, we all like to take care of our grandparents or parents or any geriatric populations. We have that empathy, or we say sympathy, but doesn't make the persons to be dependent on us. So we should make the person to be self-sufficient and independent by themselves. Some of them may be able to fold their dresses. Some of them able to keep their bed spread properly. Encourage that. Okay, we should not make the person to avoid all that things. Even that is important for us. Okay, end of life or complex care management. Sometimes the condition may not be in our hands. It may be going to the extensive state where they need a pain care management or something. So that, how will you take care of? There comes your package system, or we have education for the caregivers. This is our important. So each care pathway, when I say, it should have an intervention package. It should be fixed. Like suppose if I come with a stroke, if we have a population with stroke, you should have that stroke patient should minimum of this many exercises daily. Okay, it should be given by a physio, or should be trained to a community healthcare worker, or it should be trained to the family care worker to do that part. Okay, so that includes the care pathway is not really meant to say intervention. It will have a minimal assessment which says that what was the assessment, which it is not like name, age, sex, health, vitals and all this. That is your general assessment. Particular to that patient assessment, what is the problem which is arised and what was the reason for it. So for example, if I say the person is able to do, a Parkinson's patient is not able to walk. So your assessment will be able to see the functionality of functional position from getting up to standing and walking will be your functional aspect. That assessment will be there. And plus the persons, they have a cognition issues, that also should be there. That is the important aspect in that assessment. Okay. So if there is a comorbidity, that also will be in that care pathway. So anybody see that care pathway or that minimal recording, it should be, they should be able to carry out that particular thing even after the discharge. Okay, so that is what it is important for a care pathway. So it gives a guidance to the number of sessions, as well as how many things has to be taken, who are taken care, what are interventions was undergone. This should be the clear care pathway for the any geriatric populations. So patients with complex needs, sometimes they'll have some other conditions, or some conditions are very much problematic. They need some kind of support. So for example, motor neuron disease, okay, or Parkinson's disease. Some of the conditions may require a society. So, sometimes basal ganglia societies are there, multiple motor neuron disease society have not seen much, but there are some societies which is meant for the prevailing that particular conditions. They can get the help from that particular supporting NGOs or any societies. So this will be taking care of their functionality. Suppose their ergonomic background, or they need wheelchair, or they need some suction apparatus constantly at home, or oxygen therapy constantly at home. In these areas would be taken care by this particular societies. When I say multiple disciplinary approaches, that is an important aspect in the geriatric populations. So when we say this multidisciplinary approach, I'm not saying about the physician, occupational therapy, physiotherapy, speech therapy, or not that. The whole about the indoor areas. That means what are the patient's core symptoms? Okay, so the patient's motor symptoms or sensory symptoms or cognition issues, whatever it is, the physical, whatever the functionality, whatever comes, that is the core symptoms of the patients. The symptoms always helps the person to treat helps the physios or any those who are taking care will understand much, and we can plan for the treatment. That is why we should know about the core symptoms. Fatigue level is an important component in geriatric population. So as the age declines, I said degenerative changes happens in the musculoskeletal system and your cardiac system, your nervous system, everywhere. So the conduction of impulses also is going to slow down. So the activities which is going to be reduced and then it also reduces our endurance. So this may result in a fatigue for the patients. So the general ability would have been decreased. So fatigue also one component we should take care of. Pain. Some conditions will be having pain or associated pains that we may need to take care. Cognitive fog. Everybody may not be the thing. See, it may not be due to the head injury or the brain symptoms or multiple sclerosis or any conditions which affected the brain and result in cognitive. Even in a spinal cord injuries, patient with a geriatric population may have a cognition issues because of that adaptability, or the disturbance which happened in their life, which they may not be able to accept it. Even that aspect we may need to take care of. Sleep. As the age goes, even our sleep also is going to be reduced. So that is about one thing. Belief about the symptoms. So sometimes they feel I cannot move. This is what they say. They'll be so adamant to say that I cannot move. If I move, I will fall. So that belief in them. Okay. Sometimes the symptoms will be there for the patient, which they need to come out of it. But at the same time, you have to think of the symptom may be little more gone ahead because of their acceptability, or they are not able to accept that fact, and they are thinking that symptom is causing a lot of problems for their entire body. That will be their belief, but it may not be the right one. So that is also one thing we may have to take care. Medication and adverse effect. Medication has good effect for us, especially for example in neuro conditions, spasticity management, rigidity management. You know, after the tablets or after the injections, we may be able to manage the patients easily because we can gain the voluntary control. Or if the person is having an epileptic disorder or something, there also we have our role. Psychological factors, yes, the already existing in them, or maybe due to the condition they will have. Social factors, you know, that social acceptability. So these all components is our treatment plan. Okay, it is not really meant for the physician or to take care, or the occupational therapist to take care, of the speech therapist to take care, or a psychologist to take care. As a physio, we need to take care of all these aspects. So that's why it is called as interdisciplinary treatment plan. So we should be able to support and educate. Okay, so it's not only the particular patient, we may not be able to manage with all these areas. Sometimes we may teach the healthcare workers in a community, or we may have to teach, suppose if the community has a group of people having the same conditions, the healthcare providers will be knowing what are the activities to be carried out in the community to make these people to involve in that, so that they will be more independent, or they will be more socially active. So that is what we can do it. Or community services like group access programs in a community, or particular skills which they are doing in the community. So these all things can be used as a supporting care for these particular patients. So for example, spasticity management will be done by a neurophysiotherapist. It doesn't mean that you cannot teach your skill to others. Your particular skill will be with you. Okay. If you teach others also, the exactly what is the knowledge behind that skill and how to carry out will be more with you. But you will be always, you can always train the other person to carry out in their home or in the community, at least to minimally do it. Okay, I'm not telling the complete thing, but we can do a minimal kind of caregiving for the person's caregiver educations to the family or the community, which we can do it. Okay, so for example, swimming pool. Okay, geriatric population cannot use swimming pool. Yes, they can use it, but how will you use it? Okay, whether the normal swimming pool we use it, or we can give some other the adjustment we can do it. Gyms. Geriatric population can use the gym, but how? All the kind of exercises can be given to the in gym or any other specific programs. These all things will be able to adapt, or will be able to make up in a community, so that any geriatric populations with neuro conditions can be used. You can use that resources in the community. So suppose, for example, involvement of a community respiratory physiotherapist. The cardio physiotherapist will be able to give a proper training for the patient. They both can integrate, the neuro and cardio can integrate and work for the patient's conditions. So they can think of what is the chest. Suppose, for example, the patient is a chronic COPD patient and having a problem with the neuro. So these both therapists can integrate and work it and give a correct plan to the caregivers. That is what more important in a community. So problems to be, and when you say that these all things that I'm telling as the strategic plan, problems to be addressed is, first one is quality of life, health related quality of life. So limited to the aspects of life that are important to the evaluate in the context of health and illness. So anything when you check on a geriatric populations, what is the neuro conditions which is limiting their quality of life? Okay, so that is the one we should be identified first. Okay, so this, what is that symptom which is hindering their conditions or hindering their independency level? How we can treat that related neurological conditions? That is the thing we have to first and foremost identify. You know, cognitive health is an important aspect if you see quality of life. So how the cognitive health, we have to identify it. Sometimes when we talk to the person, geriatric population, we feel that it's their character, or we may assume they're like that. But sometimes the condition would have been that particular character or the cognition would have been developed after the disease, or sometimes it may be their character. But whatever it is, try to relate this cognition to improve, then only the physical health also will be going to be improved. That is the first one. We have to identify which aspect of the cognition is affected for the particular patients, which is hindering their quality of life. Okay, so that mental process, we may have to understand that cognitive health may be the result of physical impairments, which is making them to go into different situations, and they're not able to accept it. Sometimes the the brain neurons itself would have been affected and patient having a cognitive health problems. So in general, what happens, we have to try to improve their difficulties. So sometimes an impaired communications would have been the result of your cognitive health. So how can we teach? The patient may not be going to come back to normal speech, but how can we comprehend what is the communication we can teach the patient so that they can convey the things to the others? Sometimes there are general problems like memory issues or attention issues, concentration issues. So how will you able to try to improve? We may need a lot of patients. We may need to train the patient caregivers to give a timely programs in a day-to-day life, so that it will improve their memory and attention span or concentration. Executive function is an important thing for, especially for decision making or any judgment or whatever things happens in their life. That is very important. So these all aspect has to be separated out, and we should be able to train the caregivers to improve their cognitive health. Social health, this is one of the important aspect. In our olden life, you might have seen the geriatric population, after their retired life, they'll be coming to the their community areas, they'll be sitting, they'll be chatting and all. Nowadays, it's very rare to see that. Why? Because that social communication or social factors, which is not allowing them to do that. What happens? For example,
sorry, ma'am, please continue.
Am I audible, Tuna?
Yes, you were audible, ma'am. Someone got unmuted by mistake.
So here what happens, no patient has to be participated in social roles. So you should, when as a physios, we should make the patient, bystanders and family to understand they are also a part of their family. So any decisions which is happening in their family, they should involve this person. Usually that will not be there. So that even a small decision making at family, make them to come out of their family and do that same thing in the community. So that part need to be improved at the individual level, to the caregiver level, to the family level, and then to the community. So this is that identification where it has come, identify where it is problematic, there we have to go it. Sometimes in our normal life, what happens before the retirement or something, we say we should do assemblies, work, okay, or some schools. These all are our day-to-day life. But in old age, once it comes, they may not be going for work, but they can do home-related activities. They can do the leisure. That means they'll have a recreation. They should have a community group where they will talk each other. They'll communicate each other so that they can be having a normal life like others. So sometimes the loss of mobility, if you see loss of mobility or the cognition issues is not allowing them to go to the community. So what happens? This will restrict their social activities. So in these concerns, what happens, we can see to that in the family level itself, we can do something, okay, making them to, allowing them to be a part of their family. That is first and foremost thing. Then later on, the mobility care which we can give, even the wheelchair or the crutches or whatever the patient can be used, teach the patient to be use that at home and then come out of their house, use around their house, then the community. These all things we can help the person to do it. Okay, emotional health. So if even in geriatric population or in normal population, this is very important aspect. We have to be taken care. So this is the important aspect in quality of life. So many degenerative conditions, what happens? The neurological conditions can interfere their daily activities, and they may not be able to, they will have a lot of dependency on others. They will be frustrated, and sometimes there will be fear of what. In that aspect only, they'll be going to the bed, they'll be in the stage of bedridden position, or they'll be aloof in their rooms. They don't want to come out of it. So these things also we should be taken care by a physio. So when we think of a strategy plans, so any strategy plans can be the first strategy plan. So now we are in 2021. So what we can do for the geriatric population? The first one is we can stop the people to getting ill. That is a prevention. The prevention is the first and foremost thing which we can do is identify the people with existing disease, okay, and we can try to promote their functionality. That is one important thing we can do. Or the person who are at risk, we can plan for the prevention programs. We can do the community life. We can start with many exercise group exercise programs in the community. We can give yoga therapy. We can give responsibility to the elderly population so that they will be more active, so that they will not go for they will not go for any complications. So for example, if the person is having a degenerative disease in the lower limbs and paralyzed on wheelchair, can give social responsibility to them. So they will be, they feel elated and they will be try to do that responsibly. So that is an important aspect of a neurophysio. So it's when I say neurophysio, it's meant for actually all physios, those who take care of the patients, any geriatric population. So so that the general physical fitness is doesn't, that's why I said in the beginning is the general fitness, when I say it is not like independently walking or running or having everything, it is the physical health, or it can be social health or emotional health, everything. So if the person's physical health is declined, also make the person to use their emotional and social health to improve their independent daily activities. So that is the high standard of living a geriatric population can survive. Okay, so that is what we should teach the patients and we should encourage the persons to do. So this can be done by improving health. Okay, so sometimes we can give integrated services. Okay, we can identify the geriatric populations. We can start with a group plan. I know many physios are having their own community setups. Many colleges has come up, so they can actually, we can take up individual areas or villages. We can start with the community programs. Usually what happens now, we'll go and take a survey on osteoarthritis, treat that particular, take how many osteoarthritis are, teach some exercises, come back, or go and identify some cerebral palsy patients, teach and come back, or go and take a neuro patients, will do a stroke, 3-4 strokes are there in the village, you go treat and come back. Rest of the time, we are not taking care of what happens to the normal population, or normally having a mild neuro conditions, we are not taking care. So we should have a plan which how we can take care of the geriatric population above 60 years of age. How can we go for a survey? What are the prevailing conditions? How can we prevent not getting the conditions? Or if they have the things, how can make them more independent in their lifestyle or in social aspect? So that is what we go for. Improving health, or we can use the integrated pathways, which I said. Second one is reforming service. So we can, sometimes some conditions need to be shifted to the hospital, so we can do it. Or we need to take care of the appropriate treatments at the right place and right service and first time. It is not like, this also have, we have observed in many conditions what happens, any patient walking and coming with an osteoarthritis to the clinic, for the treatment, everybody will teach quadriceps sitting exercise, SLR, and send it. If the person is able to walk, that means the quadriceps power is 3+, no? So why we are doing that quadriceps sitting exercises? We are not thinking much beyond that, which are the areas need to be taken care. This is a simple thing I said. So in neuro conditions also same thing. If the person is able to walk, okay, why we are not allowing them to come and participate in their social aspect or cognitive aspect? We just left there. Okay, if the person is walking, our home treatment, the home physiotherapy is finished, we are come out of it. But we are not thinking beyond that, how that stroke patient is going to come out and going to be participated. So that's why I said right service, right place, and first time we should give the appropriate care. It is not only taking care of range of motion or strengthening program or whatever required for the particular neuro conditions, but how the patient is going to come to the community, because the brain has its adaptability. Why we are not utilizing, why we are not training, that is our lack. That is our problem, I feel. So we should be able to allow the brain adaptability to happen for this geriatric population so that there can be a part of community itself. So my recommendations, what I felt is emphasis on treating ill health to one of preventing ill health. One thing. Second one, support through the delivery of high quality or intermediate rehabilitation, whether we can deliver at home or closer to home. Independent self-care model has to be taught to patients, which is very much important for geriatric population. We should teach the self-management and support. Any new models or approaches for a specialized rehabilitation, for example, spasticity management, anything which is there, we need to be taken care. Develop an integrated model of intermediate care services. So suppose if anything happens, how can they take care at home, okay, itself, or they need to refer to other areas. That facilities need to develop in a community itself. Improve discharge process. Our documentation, most of the times our documentation is the one which is lacking. If the person is discharged, the another person will go to home and take physio. They don't know what happened in the hospital, what was the treatment undergone. So this also should be our treatment, our needs, everything should be documented properly and integrated whatever we are doing as a physio to the social needs. That's very much important. If possible, we trust now tele-rehab is very much popular because of the COVID. So that also, that technology, we should utilize it so that we can have a follow-up for the patients. This is what recommendations for any neurogeriatric conditions. At the same time, we always keep it in mind that there are some barriers. Okay, when I say barriers, there are some things. So when we have facilitators and we have barriers. Facilitators means the components which helps the person to be independent. There is nobody is going to stop it. The person itself, there are different components, that self, attitude, everything is there. So the facilitators means it may be from the individual or it may be from the community or the family, whatever it is. It's allowing the patient or geriatric population to be with their optimal functions. Barriers, it means any components which is not allowing the person to do its functions. So it's a two sides of coin. So we have self. For example, if you evaluate ourselves, we have barriers in our mind, right? For anything to do, anything, if you want to initiate, or if anybody, suppose, for example, one student want to do a presentation, but the person, that student is feeling my English is not good, whether I can face everyone. Okay, I have not taken any classes before. I don't know how to prepare the slides. These all are their self barriers, not allowing them to do a presentation, right? So same like that, but definitely the child is doing the physio course because the child got the ability or the percentage to do it, but the child may not have been trained or didn't get any guidance or support to do that. So somebody else is saying, no, you can do it, I will help you. So the other person or the teacher helps the person to do the presentation or guide. One or two presentation after that, the person will become out. So we all, those who are speaking here, I know everyone was a student once. Okay, and we didn't do presentations or anything, but now everybody is speaking nicely, everybody is doing nice presentations, nice slides, everything. How it is come through the practice. Same thing happens when any conditions happens to our life, even it is a musculoskeletal conditions or neuro conditions. The self-limiting factors will be always there in human beings, which will not allow the person to come out of it. So sometimes when a person, for example, when neuro conditions happens, allow the person to understand their functionality and their limitations. So we should make the patient to say that you are able to do this. but you're not able to do this. Make them self-evaluate. Okay, so that is one barrier. Second one, motivation to do things that I don't need to explain more. Ability to interact with the family or the society. Sometimes we may not be able to say to the family, or the other side person is not educated, or the person is not wanted to accept that fact. So this is also one barrier. Deal with negative attitudes. The person feels that I am like this, I'm not going to improve. That is the negative attitude. And network. These all are, they don't know whom to approach for the right thing. So these are the self barriers. That means in the patient itself. The second one is social awareness of the social awareness. So it can be their taboo or their thinking of about social awareness, social versus empathy, interact on even footing. So these all are some social things you can see. Cultural, now it is reduced, but even in India, you can see many areas have this cultural issues. They feel that whatever they have done, the karma is the one reason for all this illness. They feel that their appearance, when they go out, the way of walking, or they are in the wheelchair, that is making them to withdraw from the thing. That is also one barrier. Okay, in front of others, how do they have the food with the left hand they're having? That is a barrier. So these all are some of the cultural barriers. Attitudinal dependency. Okay, if everybody is there at home, they does everything, the patient will be feeling dependent. It is not the patient problem, actually it is the family caregivers, or we are not allowing, we are not teaching them. Lack of will or confidence. Decrease burdens on others by limiting self. Sometimes they feel, so you do this many days I was doing, no, now you do this also. Patients sometimes the attitude will be there. Okay, lack of self-esteem. Okay, that is a major problem with patients with disabilities. So this all can act as a barrier for the persons to come out of it. So how we can do is, we can do integration. Okay, we can, whenever a community physiotherapist goes, even it is a neuro conditions or any conditions, we should create an integrated therapy. Whenever we do exercises, see to that an attitude of caring or empathy with us, and also include the or inclusive of family or the caregivers and communities for the patient care. Okay, so it is not a physio alone will be doing, a family member will be doing, or a community care person will be doing. So the disabled person must be able to live like any other member of the family. So that's why, so that is what we call it as inclusiveness. So the person will be able to inclusive in their family as well as into the community decisions, so that they will be more independent. Integration means creating a space and an opportunity for the people with disability to merge with the mainstream activities or general activities of the society. So when we say disability, usually what happens, no, persons with polio or persons who lost legs or amputation, this many things only we will take care of. We never think of a geriatric population. What is that inclusiveness? We usually we always try to exclude that population. That we should not do. How we are taking care of a person with a disability, same way we should be able to take care of, irrespective of their age or gender, whatever it is. We should make them to be inclusive in the society for their activities. So by ending this, I want to say one thing. A study was published in journal Ecology and Society that says that transformation involves novelty and innovation. So we should be knowing every individual in the society is important. Either it is a geriatric population or is it a young or children, whoever it is, they have something to do with for the society. Okay, so sometimes we may need to innovate some things for that person. So sometimes in the form of a simple adaptability for them to be survive in the community, or you may have to do small innovations so that they can improve. Transformational change at smaller scales enables resilience to larger scales. So we feel that even if you do a small things, it can be shown as a larger scales, while the capacity to transfer at smaller scales draws on resilience at other scales. So thus deliberate transformation involves breaking down the resilience of the old and building the resilience of the new. So always think that we can do the transformations. We don't need to exclude as a geriatric population, or we should not put it in apostrophe and say it's geriatric population. Instead of that, think they are also a normal person like us. include them as much as possible to the community. This, even though they have conditions, general, even a 45-year-old or 30-year person also will get a stroke or head injury. So how they are surviving, how they are coming out of it. Same way we should be able to do for these geriatric populations. We should not make them to sit at home and make them more dependent on others. Okay, so too much care makes them more dependent. So that also we should be able to make the person as self-sufficient. That is more important. Thank you. Did I exceed the time, Chandramohan?
Of course, madam. But okay. So it's like happy learning. That's fine, madam. No issues. But time was taken.
I'm sorry.
Because
no
Shirisha is also
questions
there
posted
waiting.
in YouTube, ma'am.
Okay.
We request Chairperson Dr. Ramya madam to take 3 questions.
Okay, thank you, ma'am. It was really a wonderful session. You have discussed with the neglected portions, actually the cognitive aspect, the integrative aspect. I have noted the care pathway, the resettlement and self-management. Most of us are neglecting this.
Yes.
Things. So physiotherapists should focus on that, especially, and of course, the cognitive decline. Even the cognitive exercise, our physiotherapy exercises can do wonders in cognitive management. Most of us are not aware of that. We have to go through the research. It is my request. All of us have to go through the latest research to deal with the cognitive decline. And also, I can say that the open skill training community programs, along with the integrative approach, can make changes in the geriatric population. And thank you. I think, is there any question in the chat box, ma'am? Participants, please.
No questions have been posted in
It
YouTube.
will take 20 to 30 seconds, madam. Let us wait. We will take on our questions now.
Okay.
I request Rupesh and Duna, madam, keep checking our YouTube and
Yes,
kindly
sir, I'm
post
there
the
only.
questions here. Dear participants, write your queries there. And if there are more questions, we will get answers from Annie madam later. And we will be taking maximum 3 or 4 questions for the discussion. We are running out of time. And Girishar is ready. He's waiting from 12. And no issues, Annie madam, we are happy. This is happy learning.
Thank you.
Thank you, ma'am. Once again, thank you, ma'am, for sharing.
Thank you. Yeah.
Any questions, Duna madam?
No questions, sir. Thank you, Annie Thomas ma'am and Professor Ramya ma'am, for setting up time aside from your busy schedules to share some valuable information with our delegates. Thank you.
Thank you.
Thank you, Annie madam. Thank you, Ramya madam.
Thank you.
Thank you, Annie madam. Thank you, Ramya.
Thank you, sir.
Yeah, Aroma ma'am, can we go for the next, please? Kindly unmute. Yes.
Kindly check Girishas is there. Yes, Girishar is there.
Yes.
Next, I would like to welcome our next chairperson, Dr. Jibu George Varghese, sir. He possesses 16 years of academic experience and he currently working as a senior consultant physiotherapist at Revival Institute of Manual Therapy, Chennai, India. We are so privileged to have you here, sir, to grace this event and host this session with our next chairperson, Dr. Girish, sir. Over to you, sir.
Thank you, madam.
Girish, sir.
Very much. Am I
George, sir, your
audible?
voice is breaking, sir.
Okay. Am I audible
sir?
now, sir?
Yes, sir. You are audible, sir.
Okay, thank you. I suppose there might be a small lag. We had some issues with the internet because of the rains. Anyway, I would like to take this opportunity to thank Mahesh sir and the management of Sree Anjaneya Institute of Paramedical Sciences for inviting me and also the co-organizers, Dr. Chandra Mohan, and our very own Dr. Rupesh, for inviting me for this session as a chairperson. And I go to my responsibility of introducing the speaker for this session, Dr. Girish N., who is an associate professor in the Department of Physiotherapy at the Manipal College of Health Professionals. And he has also completed his doctoral studies from the National Institute of Industrial Engineering at Mumbai. His area of interest includes sarcopenia, frailty, aging, research, ergonomics, and worksite wellness programs. He has focused on the delivery of care to community dwelling and institutionalized elderly to improve their physical activity and maximize their independence. With the expansion of geriatric care, he has focused his research work in balance and gait, cognition, physical activity, bone and muscle health, and frailty among older adults, and has 22 publications in index journals. He is currently the in charge of the Geriatric Physiotherapy Training Program at Manipal and has 14 years of experience in supervising both the postgraduates and the undergraduate students. Sir, I welcome you, and I request you to take on from here.
Thank you, Dr. Chibu, for that kind introduction. Can someone just confirm whether my audio, I'm
Yes,
audible?
sir, you are clear. Very clear.
Sir,
Okay,
yes, sir,
fine.
you are audible, sir.
Are my slides visible? I've shared my slides. Are they visible?
Your slide is visible, sir.
Okay, fine. At any moment, if there is any technical issues, please let me know.
Sir, is there anything written in that slide or simply?
No, it's a blank slide. Yeah.
Okay.
Fine. Yeah. Yeah. Good afternoon, one and all. Before starting, I would like to thank the organizers of this conference for inviting me, for giving me an opportunity to talk with you all. Yeah. I would like to start this session with a question. Can falls in older adults be prevented? So I understand that the conference is running late, and I assure you that I won't exceed my time. So in the next 25 to 30 minutes, I'll be talking about falls in older adults. Yeah. Before going into the details of falls, let us understand what is a geriatric fall. So for the undergraduates who are attending this conference, you need to understand balance before understanding fall. So balance, as defined by Cook in 2001, is the ability of a person to maintain the body's center of mass over its base of support. This definition essentially holds good for the static balance or static postural control, what we say. And there is another component of balance, that is the dynamic balance, which is nothing but the ability to maintain the body's equilibrium or body's stability, even if the line of control or the center of gravity is line of gravity or center of gravity is moved beyond the base of support. And in 1987, the Kellogg's International Working Group on Prevention of Falls in Elderly, they have defined fall as an event in which a person comes to rest unintentionally on the ground or a lower level surface, and not due to an acute overwhelming event. This definition they have framed for the research purposes, and they considered these acute overwhelming events as acute onset of paralysis, syncopal attack, epileptic attack, sudden loss of consciousness, or sustaining a violent blow. And later on in 2005, Lamp et al. Has redefined it as an unexpected event in which the participants comes to rest on the ground, floor, or a lower level surface. And irrespective of the reason, if a person is coming to rest onto these lower level surfaces, it should be considered as fall. And nowadays, for the clinical purposes and even for research purposes, lowering of center of gravity from its resting position is considered to be a fall. So as we all know, center of gravity is situated at the anterior aspect of the S2 vertebrae. So if a person is losing balance and that center of gravity is getting lowered from its resting position, should be considered as a fall, even if the person is not falling onto a lower level surface. Now a little bit about the epidemiology of geriatric fall. What are the consequences? What are the incidents, etc., of geriatric fall? As a consequence of fall, a plethora of events can occur, which could be consequences like physical consequences, which could be lesser problems, less serious problems like cuts, bruises, lacerations, or even sprains or strains, or more serious consequences like fractures or traumatic brain injuries. Then psychological problems. In the last session, Annie ma'am has explained about the fear of fall, the loss of confidence, etc., which could happen. Then social issues like isolation, then poor quality of life, then economic problems like increased healthcare expenditure, increased hospitalization and expenditure for surgeries, etc., etc. Let's see the incidence of geriatric fall. It is reported that 1 out of 3 individuals who are above 60 years fall in a year. And as the age increases, for example, above 80 years, that rate goes to 2/3 of the elderly, and almost 3/3 or almost 100% of the older adults who are above 90 years fall in a year. So almost everyone reports a fall above those who are above 90 years. And these falls are less common in people who require the lowest level of support and the highest level of support. So the lowest level of support, they are the people who are elite or who are fit older adults who have basically good amount of balance, and the lowest amount of or the highest level of care, they are the ones who have who will be dependent on a caregiver for most of the time. And these two individuals, these two group of individuals report very less number of falls, whereas the middle group of people who are frail or who are independent in their daily activities, then that group of people report fall more often when compared to the other two groups. Now, in 2018, Cameron et al. Has reported that institutionalization, that is putting an older adult in a care setting, that is old age home or other nursing care homes, etc., reports higher number of falls when compared to a non-institutionalized person. Then older adults in the lower socioeconomic status report higher number of falls. And with regard to gender, it is men who report more number of fall, whereas women report more number of injurious fall. Even though men report more number of falls, the injuries among them, the traumatic issues in them will be very less when compared to women. So traumatic falls are more common among women when compared to men. Now, just one slide about the risk factors for fall. So if you search on the risk factors for geriatric fall, you will get probably 2 categories of risk factors, the intrinsic ones and the extrinsic one. Okay, the intrinsic risk factors are pertaining to the individual, and extrinsic factors are pertaining to the environment. So basically, a fall is due to the interaction between these 2 categories of risk factors, the intrinsic ones and the extrinsic ones. So if you see the individual risk factors like age-related physiological changes, then history of previous fall, then giddiness or dizziness, then cognitive impairment, gait and strength deficits, visual and vestibular loss, sensory or motor problems, and behaviors and choices. Then the extrinsic reasons, extrinsic risk factors for fall, if you see, they are medications. In the first session, Dr. Sheetal mentioned about polypharmacy or multipharmacy. that is a person who is taking more than 3 medication, let it be any kind of medication, more than 3, if they are taking, they are at risk for fall. And if there are antipsychotic medications or antidepressants in that 3 medications, then the risk for fall increases many times. Then poor lighting, slippery floor, uneven surfaces, usage of assistive devices, then inappropriate footwear, inappropriate clothing, then unstable furniture, low beds and toilets, etc. are the other extrinsic causes or environmental causes for fall. Yeah, and this paper is for the postgraduates who are attending this conference. This is a beautiful paper which talks about the epidemiology, then risk factors and strategies for prevention. In this particular paper, they have mentioned that they have identified more than 130 risk factors for geriatric fall. So those who are interested can refer to this paper. Also, the surprising fact is that even though there are 130 above risk factors identified, those who are above 75 years who fall, around 10% of the people doesn't have, when they screen, they doesn't have any of those risk factors. So even though there are no risk factors, there could be falls. And in this slide, there are few black-colored risk factors, and there are few red-colored ones. The red-colored ones are the potentially, modifiable risk factors, okay, which we can address. Okay, whereas the black ones, they are the non-modifiable risk factors, which is very difficult to manage. Now, why do older adults fall? Okay, if you see the incidence, I've said before, it ranges from 33% to 100% in elderly population. Now, in order to understand why older adults fall, you need to understand the physiology of balance or physiology of postural control. So if you see balance, I'm sure the postgraduates will be able to appreciate this particular diagram. Balance has got 3 parts, basically the input, then the central processing and the output. So if you see input from your eyes, that is the visual input, then from your ears, that is the vestibular input, that is from the semicircular canals and the utricles and sacules in the inner ear, which sends signals regarding the linear and the angular acceleration and proprioceptive inputs from the proprioceptors, which are around your joints and the muscle. Okay, these inputs sends impulses or send signals to your higher centers in your cerebral cortex and at the brainstem, specifically the cerebellum and the basal ganglia, where central processing happens, and it further sends descending outputs via the cerebrospinal tract, which in turn controls the musculoskeletal system for maintaining the balance. Basically, the strategies for balance, the ankle strategy, the hip strategy, the stepping strategy, or your suspension strategy. So this is how the physiology of balance works. And maintains the equilibrium of our body. So as we age, okay, you can see the structural and functional deficits in all these areas. For example, the visual inputs will be affected, the vestibular inputs will be affected, the proprioceptive input will be affected. Also, there will be changes at the central nervous system, which in turn hampers the central processing, and the output part also. You have, there will be decline in the muscle strength, there will be decline or deficits in the range of motions, etc., which affects the strategies to maintain your balance. Again, this paper explains the human postural control. Those people who are interested in can refer to this paper. This paper explains the physiology of balance in detail. Now, how to identify balance issues in older adults? Now, American Geriatric Society and British Geriatric Society, they have jointly developed a fall risk algorithm, which basically explains and guides you how to approach an older person who is a potential faller and how to progress with assessment and management. So this group, the American Geriatric Society and British Geriatric Society, they recommend you to consider every older adult, any person who is above 60 or 65 to be a potential faller. And you should follow this algorithm when you see them, when you encounter older adult. So older person encountering a healthcare provider, you need to take three things. First of all, you need to see whether the person is presenting with an acute fall, whether the person had 2 or more falls in the past 12 months, and whether the person is having difficulty in balancing or difficulty in walking. If the answer for this is yes, then you should undergo a multifactorial fall risk assessment. So multifactorial fall risk assessment is very much similar to the comprehensive geriatric assessment, which Dr. Sheetal spoke in the morning. So it should include a history of fall, which consists of the onset of fall, whether the fall is a sudden fall or a gradual fall, then the mechanism which led to fall, the circumstances which led to fall, etc. Then take the medication history, then check for the risk factors with regard to the visual system, vestibular system, then undergo a balance evaluation, muscle strength evaluation, then go ahead with environmental hazard evaluation and functional assessment of the person. After that, initiate a multifactorial or multi-component intervention, which includes deep prescription of medication, then individually tailored exercise program, treatment of the visual impairments, then vitamin D supplementation, then management of postural hypertension, footwear prescription, and then environmental modifications and patient and caregiver education. And if the answer for your initial 3 questions is a no, that is, the patient doesn't report to you with an acute fall, or the patient doesn't have 2 or more falls in the last 1 year and doesn't have any difficulty in walking or balancing, then the next question you should ask is whether the person had a single fall in the past 12 months. And if the answer is yes for that, then you need to undergo a detailed balance evaluation for that. And if balance deficits are identified, you should refer the patient for the multifactorial fall risk assessment, followed by multi-component intervention. They recommend the usage of timed up and go test for evaluating balance and categorizing older adult into a faller, a potential faller, or a non-faller. And if the answer to this is no as well, then reassess periodically. And they recommend reassessment at 6 months interval if the person is a non-faller, and if the person is a faller or a recurrent, or if the person is having a history of recurrent falls, multiple falls in future, then they recommend to reassess the older adult once in 3 months. So that's it about the fall risk algorithm. So it is basically a flowchart which guides you, or which helps you to approach, helps you how to approach an older person who is coming to your clinic. Yeah. Now, how to test balance in an older adult. Now, we have basically static balance test and dynamic balance assessment test. Okay, the static balance assessment test is in the form of a pyramid. So at the base of the pyramid, you have the person, you need to test with the person standing with his feet together. So this picture is the footprint of the person. So we should ask the person to stand. We should ask the person to stand with the feet touching each other. The person can do that. Person can hold in that position without losing his balance for 10 seconds or more. then you should progress to the next stage, that is semi-tandem stance. Here the person will be keeping one foot ahead of the other. The medial aspect of the heel of the front foot will be touching against the ball of the medial aspect of the great toe of the foot, which is placed behind. Then the complete stance. So this is further progression of the test. So the person is able to maintain more than 10 seconds, then progress to tandem stance. Whether in that position, the person will be standing with one foot in front and another foot behind on a line. If the person can hold without losing balance or without causing much of perturbation, then progress to single leg stance test. And if the person can hold that position as well for 10 seconds or more, then progress to the dynamic balance test. So basically in static test, we are testing the ability of the person, whether the person can control his center of gravity or line of gravity within the base of support. Whereas in the dynamic test, we are actually pushing the center of gravity or line of gravity beyond the base of support and how well he is retaining his balance back or the posture back. So these are few dynamic balance tests, the forward reach test. These are the simpler ones, the forward reach test, in which we'll be asking the person to stand with the normal base of support. Then we'll be keeping a scale beside the person on the wall. Then we'll be asking the person to lean forward safely, how much the person can, and come back to his resting position. And a person who is reaching forward for more than 20 centimeters is considered to have adequate balance, adequate functional balance, and the person is considered to be at lower risk for fall. Next is multi-directional reach test, similar to the previous one, the forward reach test. Here you will be asking the person to reach in multiple direction, that is forward, then sideways, right and left sideways, and backwards. The backward distance should be 10 centimeters, and all this other ones, the forward, the sideways reach should be, the cutoff score for that is 20 centimeters. Next is timed up and go test. Most of the screening tools recommends the usage of timed up and go test. It basically evaluates the balance of the person and the functional mobility of a person. Okay, in timed up and go test, you will be asking a person to get up from a chair, an armed chair. You'll be asking the person to walk for 3 meters ahead, then turn 180 degrees, come back and sit. And it is a time test. You will be starting the timer at the command go, and you will be stopping the timer when the person sits and rests his back against the backrest of the chair. And the cutoff score for this timed up and go test is 13.5 seconds. So a person with adequate functional balance should be able to complete the test within 13.5 seconds. And a person exceeding that 13.5 seconds is considered to have poor balance and at risk for fall. Next is four-square step test. So basically you have four square like 1, 2, 3, and 4 squares. So the person will be, again, it is a timed test. The person will be standing initially in the first, on the first square, and when the timer starts, the person need to go forward to the second square, then walk towards the right side, towards the left square, then walk backwards towards the fourth square, then left side into the first square. Then he has to come back from that position to the original starting position. And the cutoff score for this test is 15 seconds. So a person with adequate functional balance should be able to complete the test within 15 seconds. Then you have other balance measurement tests like Berg balance scale, then Trinity performance oriented mobility test, and Fullerton advanced balance scale. So these are not basically the screening measures. Okay, these are mainly used for the research purposes. Even for clinical purposes also it is used, but it is little time consuming. All the three ones requires minimum of 20 minutes to 40 minutes to administer. Okay, work balance scale, it has got probably 14 components you need to administer, and each component is being rated for from 0 to 4. And the total scoring would be 56, and a person scoring less than 45 is the cutoff score for older adults. Less than 45 is considered to be at risk for fall. Then TNT performance oriented mobility assessment. Again, it has got the balance component and the gait component. The total scoring is out of 30, and the person should score more than 24 to consider himself to be at the safer zone. Then Fullerton Advanced Balance Scale, again, the total score is out of 40, and a cutoff score is for 25. So more the score, better the balance, and lower the score, poorer the balance. This is basically for the postgraduates who are attending here. This slide talks about the psychometric properties of these outcome measures. So any measure which is above 0.8 also is considered to have considered to be good. So almost all the scales are better in terms of reliability and validity for older adults. Yeah, again, the systematic review basically compares the different tests, the static and dynamic ones for older adults, the tools which are used for assessing fall risk in elderly. It's a beautiful paper. Those who are interested can refer to this for further information about the outcome measures in which is used for falls in older adults. Yeah. Now, moving on to the management aspect, how to manage balance issues among older adults. Now, you have plenty of options available in the research arena as well as in the clinical arena, which includes exercises, then managing medications, which would be dealt in detail by Dr. Sheetal tomorrow, deep prescription of medications, then environmental interventions, then risk factor management, usage of assistive technologies, psychological interventions, then education of patient and caregivers, and nutritional interventions. So these many categories of basically the categories of interventions are available to manage falls or to improve the balance issues among older adults. Now, this is what research says. You should not focus on single model fall prevention program. Always focus on multi-model fall prevention program, which is like you should not solely depend on exercises alone to improve balance and prevent falls. So along with balance, you should incorporate probably deep prescription of medications, or educating the patient and caregivers, or risk factor assessment and risk factor management, etc. So rather than focusing on single model intervention, you should always focus on multi-model interventions. This is slightly older paper which talks about the evidence of these intervention for older adults. It is almost 10 years old now, and we are expecting a revision soon. So recommendation for practice of prevention for fall in older adults, which says, this is the evidence rating for each, and evidence rating, rating of A says that it is having strong evidence, then B as moderate evidence, and C as weak evidence. So if you see multifactorial risk assessment and multifactorial intervention has got a good evidence for fall prevention. Then exercises, that is our area. Exercises, particularly balance exercises, strengthening program, and gait retraining program has got very high evidence or strong evidence on improving balance and fall prevention. Also, you have nutritional intervention, especially the vitamin D supplementation, especially in prevention of fractures after a fall. Now, I would spend probably 5 minutes to discuss about the exercises which are being used for managing balance issues. So you have balance retraining exercises, then strengthening exercises, gait training program, coordination exercises for the lower extremities and upper extremities, then agility programs, and dual task exercises. Okay, so basically, these are the exercises which are currently being administered to older adults to improve their balance and preventing future falls. Again, there are this is basically for the postgraduates who understand about systematic reviews and meta-analysis. There are reviews which are available, which compares various exercise programs, various intervention programs for older adults, and which again emphasizes on the multi-component exercise program. So, which means that you should not again concentrate on single component of exercises. So, along with balance retraining program, you should strengthen the older adults lower extremity muscles or proximal muscles. Along with that, you should incorporate agility program. As that improves, you should improve the lower extremity coordination, then probably reflex reactions, etc., etc. Again, this slide is for the postgraduates who are attending this. There is a Cochrane review which is available, which talks about the multifactorial and multi-component intervention. And they basically compares the multi-component intervention with single component intervention. And this is the result of that paper. This is basically the forest plot, which explains about, which has, pooled the effects of all the papers together. There are 19 papers which have used multi-component interventions. And as you can see, after pooling all the results, okay, the lower diamond shaped thing, it is shifted towards the intervention part, which means, okay, multi-component intervention is considered to be having an advantage over single component intervention. Now a little bit about the balance exercises management. So when you start exercises for older adults, you should always start with improving the sitting balance in static and dynamic. Then once that is achieved, then progress to the standing balance exercises. Start with wide base exercises, then standing with normal base, then progress to standing with narrow base, then semi-tandem, then tandem, and finally single leg exercises in standing. Now, how to that is how you should initiate the exercise program and probably to progress the exercise program. Now, how to progress further in that exercise program? So there are certain principles upon which we should progress the exercise program for older adults. That is, gradually reduce the base of support. So initially start with a wide base of support and gradually reduce the base of support to narrow base, which you have seen in the previous slide. Gradually challenge the line of gravity or center of gravity. That is, static exercises initially, then progress to dynamic exercises. So perturbation or reach outs, etc., should be started once the person achieve static balance in that particular position. So you can use certain devices like wobble board, then balance beam, then T-bow, etc., to improve the balance, which actually challenges the line of gravity beyond the base of support of that person. Then gradually wean off multiple inputs. So this is the last principle which says, initially all the program should be started with eyes open position, then slowly wean off that visual input. So the person will be more reliant on his proprioceptive inputs and vestibular inputs. Also, if you want to wean off the vestibular or the proprioceptive input, you can use Bosu ball, which you can see in this picture, or the foam, which is nothing but sponge basically, okay, which eliminates the proprioceptive input to that person, and the person has to rely more on the visual and the vestibular ones. Also, in the last few years, maybe last 10 years, you will be able to see multiple papers on virtual reality, gaming, etc., to improve balance in older adults. So, if you have the facility, if you have the technology, you can make use of gaming, virtual reality training, etc., to improve the balance of older adults as well. This is just one slide about the exercise prescription part. So strength training and balance training should be done for older adults. It should go in hand in hand. So more than 2 days a week is recommended. So for strength training, initially start with 40 to 50% of 1 RM and progress to 60 to 80% of 1 RM. Whereas intensity of balance exercise, there is no clear-cut explanation. So if the person is able to perform the lower activity with ease, then you can progress to the next intensity of balance exercises. So if you see that pyramid, if the person is able to stand with narrow base of support, then progress to tandem standing or semi-tandem standing, etc. Then with regard to the time of exercise for strengthening program, 1 to 3 sets for of 8 to 12 repetitions for that particular muscle, and for balance training it ranges from 10 minutes to 50 minutes. The type of strengthening, progressive weight training or body weight training, especially most of the papers have recommended strengthening of the proximal muscles initially. So core muscles, then hip abductors, then hip extensors, the proximal muscles of the body initially should be strengthened. Also, when you train the person for balance exercises, you should ask the person to contract his proximal muscles as well. So when the person is in tandem standing position, okay, you should not ask the person to just adopt that position alone. You should ask the person to contract his core muscles, okay, contract his proximal hip muscles, contract his hip extensors, hip abductors, etc., and maintain that position, which seems to be more effective when compared to just standing alone. Yeah, that's it about the exercises. Now, just one last slide: how to prevent injurious fall. Okay, so even if we give these exercises, there can be a group of people who may not improve. So in that, for those group of people, they have recommended the usage of martial arts safe falling technique. Okay, so here the purpose is not to prevent fall, but to prevent injuries sustaining because of a fall. Okay, so here we have to train the person as shown in this pictures, these two pictures. The person feels that the person is losing balance. The person should lower his center of gravity. He should squat down immediately and fall like this towards one side. So instead of falling from a higher position, higher center of gravity position, he can lower his center of gravity position and fall towards one side, thereby reducing the trauma because of a fall. Yeah, that's all I have for today. So to conclude, as a take-home message, I'll go back to my initial question. Can falls in older adults be prevented? Yes, definitely we can prevent. We have a major role as a physiotherapist. We have a major role to prevent the falls in older adults. So risk factors for geriatric fall is identified, and probably 80 or 90% of these risk factors are potentially modifiable. So we can identify the risk factors at an early stage and modify the risk factors, thereby preventing the fall. Fall screening is a must for all the older adults who are approaching you. Then, yeah, instead of focusing on a single factorial or single component intervention, focus on multifactorial, multi-component intervention, which works better when compared to single component intervention. Also, technology in future will play a major role in preventing falls as well. A lot of studies are happening with regard to Internet of Things, then artificial intelligence, wearable devices, etc., in improving the balance and preventing falls in elderly, which I have not touched upon in this talk much, but you need to understand that it will happen probably down the line in another 5 years or 10 years. Definitely technology will help older adults as well in preventing falls. Yeah, that's all I have. If you have any doubts, please feel free to ask.
With your permission, George sir, I am posting the queries from YouTube in Zoom chat box. Kindly check.
Okay. Yeah, I can see the question. Vijay Nambi posted. Is that terms balance and postural control same or different? Yeah, these are basically the terminologies used for research purposes. If you see clinically, both are same, but various researchers use it differently for their research convenience. That's it. But clinically, both are same. Then is that there is any correlation between respiratory muscle weakness and balance or falls? Yes, very interesting question. There were a lot of research done on people with respiratory conditions, people with COPD, people with emphysema, people with bronchiectasis, etc. Lot of balance issues has been reported among them. So there is definitely a correlation between respiratory muscle weakness and falls in older adults as well. Yes.
Thank you so much, sir. I found no questions in YouTube anymore. George sir, can you please handle the rest?
Yes. Sir, Girish sir, with your permission, I would just like to add. We know that diaphragm is one of the major muscles for respiration.
Your voice is breaking here, sir. Jibu sir.
And the attachment of
kindly unmute Chandramohan sir
also to the level
if you are saying something.
12th rib, it's again stabilized by the apparatus lumbar.
I think we can request him to stop his video so that his voice will be clear.
Jibu sir, kindly unmute.
Okay, am I audible now? Am I audible now?
Yes, sir.
Better, yes.
Okay, I'm sorry about that. I actually lost the entire thing. So we have
sir, again your voice breaking. You can kindly keep your video closed so that your audio comes better.
11th and 12th. Am I audible?
Yes, sir. Yes. Better, sir.
Okay. Okay. So since the diaphragm is being attached to the lower ribs, and again the lower ribs are being stabilized by the quadratus lumborum, which again the quadratus lumborum is connected to the pelvis, stability of the pelvis. So definitely respiration has a big deal to do with the balance and the falls. But and Girish sir has given a detailed connection or a detailed table of contents of how to go about or what exactly is the role of balance in the elderly population. And along with that, along with gaining confidence of the elderly population is also one of the difficult tasks when handling the geriatric population, especially with the question of dignity and
Your voice lost, sir. Jibu sir, you there? Girish sir, are you able to hear Jibu sir?
No, madam.
It's okay.
I think sir was telling about the psychological aspects. Definitely, I do agree with that. Purposefully, I didn't touch upon that. Especially if the person had a fall, then loss of confidence, then fear of another fall. Okay, those things are major risk factors which can interfere with their day-to-day activities. So along with exercise-based interventions, probably psychological interventions to improve their confidence, to reduce the fear of fall, etc., should be parallelly carried out.
Thank you, sir. Thank you. I think Chibuja is not available there. Once again, you can check, madam. Puna, madam.
Yes, sir. Sir is not there in the Zoom
I
meetings.
request Makesha to inform him that we are
yes, sir,
moving on to the next. Yeah,
please
yeah,
continue.
yeah, please.
Sir.
Please
carry on.
No,
Sir,
no,
with your
he is
program.
there, sir. He has joined.
I had some network issues.
Yeah.
So it was an excellent presentation from Dr. Girish.
Thank you, sir.
Thank you so much, Girish sir. We rarely get this kind of opportunity to listen to the words of a great knowledgeable speaker. Thank you, Dr. Jibu George Varghese sir, for setting time aside from your schedules and
My
sharing
pleasure.
your valuable information. Thank you, sir. May I have Mrs. Aroma, madam, for the next one?
Yes, ma'am. Then, ladies and gentlemen, I think it's best for lunch break announcement. We will be resumed here at 3 p.m. Participants, those who register for e-poster should remain online until your presentation is over. I would like to call upon Mr. Stalin and Mr. Jit to host the e-poster session. Thank you.
Yes, madam. I would like to add some information. Yes, we will take 10 minutes break and we will provide a separate Zoom link for e-poster presentation, which is also connected to YouTube. So all the participants can watch that program also in our YouTube channel. Then once again, we will announce post-lunch scientific session, and then everyone can join for the another link. And I think, Jasil sir, you want to talk anything?
Hello. Yes, sir. Hello.
Yeah, please, sir. Please. Yeah.
Sir. I would like to brief up today's sessions. We had a long session starting from 8 o'clock. Yes. So I'll just brief up today's session. So GERICON
in the evening, sir.
Evening, yeah.
In the evening.
Okay.
At the end of today's scientific session, sir.
Okay.
Yeah.
Fine.
Thank you, sir. Thank
sir.
you all. Thank you, Girish sir, and thank you all dignitaries. We are taking for 10 minutes break for e-poster session. For GERICON participants, we will be connecting again by 2:50 or 2:55, and the program will start by 3 o'clock. In case of any delay or any other information, we will update through WhatsApp group. Thank you all.
Thank you, Mukesh sir. Thank you, Chandramohan sir. We'll be winding up this session.
Yes, madam. Kindly end this session for GERICON team posters. We will